improved by an entire letter grade, and 25% saw it improved by 2 letter grades. I'm Tormund.
Gather the elders and let's talk.
I'm John Hawes, RN, founder of NCLEX. And in this video, I'm going to give you my top 5 test-taking hacks for nursing students step by step. So keep watching. Did you know that in 2018, 87,371 nursing school graduates failed the NCLEX RN? That's more potential nurses than there are hospital beds in Alabama, Alaska, Arizona, Colorado, Connecticut, Hawaii, Idaho, Iowa, Kansas, and Kentucky combined. At NRSNG, we have a 99.42% NCLEX pass rate. The difference? It's our process. And today, I'm going to share with you 5 of our best test-taking strategies. Now at the end of this video, I'm also going to give you a cheat sheet with 11 test-taking tips, and I'm going to jump on the computer and do some practice questions for each of these tips. So hang on till the end. All right, let's kick these 5 tips off with tip number 1, which is understanding nursing priorities. Priority nursing questions can be terrifying as a nursing student, but think about it this way. When you show up for your first shift as a nurse, you're going to have a task list that's 3 miles long of things to do, and they all need to be done now. So let me show you how to answer nursing priority questions and think about priorities in your real life as a nurse. The most common tool taught to nursing students to address priorities is Maslow's hierarchy of needs. Now, while this is super thrilling to learn, I want you to forget about it when it comes to nursing priorities. Don't tell your professor. Instead, we're going to use what we call the ABC's DEF staircase, which stands for airway, breathing, circulation, safety, discomfort, education, and feelings. This simple mnemonic will help you remember the proper order for your nursing priorities. If a patient just fell out of bed, but they aren't breathing, do I worry about getting them back in bed or educating them on proper call-out use? No, I worry about their airway and their breathing. Now with that, it can be tricky to remember the difference between airway and breathing. Think of it this way. Airway means getting air into the lungs. Breathing means gas exchange of that air. One area you might get tripped up with nursing priority questions is when to call the provider. These answer options can be tempting because sometimes we'll think, well, I don't know what to do. Let me just call a provider and let them worry about it. But there's a better way to approach these options. Anytime you see call the provider as an answer option, think, if I leave my patient's room right now to go call the provider, what happens to the patient? Is there something I can do within my nursing scope of practice? And if I don't do that and leave, what happens to them? Don't call the provider until you've done everything you can within your scope of practice to make sure the patient is okay. Now it's time for the second tip of this list, the SATA success pyramid. SATA stands for select all that apply. You know, the ones that say select all that apply and then have 3,000 options listed. For many nursing students, these are the bane of their existence. But have no fear, SATA questions can be answered very easily using the SATA success pyramid. And it's a super simple 3-step process. When you realize you're answering a SATA question, the first thing that you do is you cover all the answer options, whether with your hand, a piece of paper, whatever. Then you evaluate each answer option individually, physically moving your hand down or your paper or whatever it is. Lastly, as you evaluate them, you turn each question into a true-false statement. Where most nursing students fail with SATA questions is they read answer option A and think, well, that's really similar to B, but it's also kind of like C too, so they begin trying to force answer options to work together. When you isolate each option and make it a simple true-false statement, your success rate for SATA questions will skyrocket. Now, are all select all that apply higher level questions on the NCLEX? Well, yes and no. While it isn't required that SATA questions be higher level of difficulty, generally speaking, SATA questions are going to require more analysis level thinking, which is the higher level of Bloom's taxonomy. Now, if you're thinking, what is Bloom's taxonomy? Check out this short video, wherever it appears, where we discuss Bloom's taxonomy. Now, don't get too caught up worrying about difficulty level or how many SATA questions you've seen. Just apply the SATA success pyramid on your next exam and watch your scores climb. All right, 2 steps down, 3 to go. I hope you guys are feeling better. I don't ever want you to hear again.
While that is correct, it is not the most correct.
No! What does that even mean? All right, guys, with that, let's jump into tip number 3, which is absolute words. When it comes to nursing tests, absolute words are absolute red flags. Don't pick these answer options. Examples of absolute words are always, never, none, all, and every. If you see one of these words, run. Why is that? It's because no 2 patients are the exact same. It's near impossible to say that you should always do the exact same thing for every patient. Now with that, let me give you 2 exceptions to this rule. If it's a safety issue and it can be applied to many types of patients' populations. And let me give you a specific example of that. If an answer option says, never lift a Foley bag above the bladder. Is this a safety issue? Well, yeah, because we don't want to cause a UTI. We don't want that backflow and cause a UTI. And can it be applied to many kinds of patients? Do we lift a Foley bag above a pediatric patient? No. How about on a geriatric patient? No. It's really that simple. I know you're never going to forget that tip. All right, tip number 4, stay true to the nursing process. You might hear the nursing process slightly different from what I'm going to share with you, but essentially, any way you hear it, it's saying the same thing. Assess, diagnose, plan, implement, and evaluate. Never break this process, ever. Never, never, ever. Now, I don't want you to overthink the nursing process. This is basic stuff. It's really the scientific method you learned in elementary school, but we're just applying it to nursing, and we use it in our everyday lives. Look at an example. I wake up in the morning and check the weather. It's cold, so I plan my outfit. I put a sweater on, I go outside, and it's a bit warm, so I start the process over. Change my outfit. It's really the same with nursing care. You don't skip a step in the process. Don't start doing things on your patient until you've assessed, made a diagnosis of the situation, and made a plan. I'm not going to beat a dead horse on this tip, but just learn to appreciate the nursing process and the structure that it provides to you as a nurse, and remember to never skip a step. Never, ever, no matter how good an answer option might appear. All right, lastly, tip number 5, don't fall for NCLEX question traps. Every now and then you're going to come across an infamous NCLEX question trap. Look, the NCSBN, who administers the NCLEX, wants to be sure that you're a safe nurse and that you don't cause any harm to a patient on your first day as a real nurse. To do this, they use a couple little traps to see if you really know the nursing process and if you're willing to slow down and make the right decision, not just any decision to do something for your patient. So here are 5 traps that you can avoid on the NCLEX and in nursing exams. I'll list them and then give you some examples. No assessment, incomplete assessment, first doesn't always mean assessment, action doesn't always mean implementation, and determine the outcome for each answer. Let me give you some examples of these. No assessments complete. I used to see this a lot when I worked in the hospital as an RRT nurse, where I would rapid response team. We would get called a couple hours after blood sugars were checked and insulin was due. A lot of times we would arrive, take the blood sugar, and see that the patient's sugars were below 20. Even in the teens, sometimes even below 10, the patient was unresponsive. As we would look at the MAR, we would realize that what had happened is the tech had checked the blood sugars. Then a couple hours had passed. The nurse came and administered insulin based on blood sugars from a couple hours ago. No assessment had been complete and the patient was put into danger. Another one is incomplete assessment. An example of this might be, you see a question that says, you're taking care of a diabetic patient. You walk past the room and the patient's shaking. And one of the answer options might be, administer D50 immediately. That can be tempting because we want to get those blood sugars up. But we haven't even completed a full assessment. The first thing we need to do is check blood sugars. This patient might be an AFib or they might just be cold. Number 3 here is first doesn't always mean assessment. This is really a semantics thing. we've got to separate our mind from the first is always assessment. While it's the first step in the nursing process, if they say, what would you do first? Realize where you are in the nursing process and what the next action should be. With that, that leads into action doesn't always mean implementation. With the example I gave before, the first action would be complete your assessment, get a blood sugar. So just separating first an action from assessment and implementation. Then lastly, determine the outcome of each answer. When you read an answer option and you think about selecting it, think, if I do this and then clock out and drive home, what happens to my patient? What's the outcome for that patient? Is it going to be good or bad? And only select those things that keep your patient safe. You can pass nursing exams and you will pass the NCLEX. Inside NRSNG Academy, we help you cut the fluff, improve your exam scores, and feel better prepared for life as a nurse. Click the link in this video and in the description to get a full list of 11 test-taking tips for nursing students and to check out our test-taking course. Now lastly, let's go jump on the computer and I'm going to show you examples for all 5 of these steps. These example questions are coming from a book called Test Success by Patricia Nugent. I highly recommend you head over to Amazon, grab yourself a copy. It's a really great book and it will greatly help you in nursing school. This first question says, what should be the nurse's first action before administering an enema? Verify the physician's order, collect the appropriate equipment, arrange for the bathroom to be empty, or inform the patient about the procedure. All right, what tip can we use here? Well, if we look at first action, we realize this is a priority question. It's wanting to know, do we understand nursing priorities? So we've learned that we can use the ABCs, DEF, and we can also use the nursing process here. So verify the physician's order. Is this an ABC, DEF? Well, yeah, sure. This is a safety issue. Collect the appropriate equipment. That goes into nursing process. That goes into like implementation. Arrange for the bathroom to be empty. If we think ABCs, DEF, that's a feeling thing. We want the patient to feel safe and to make sure that they're okay. And then 4, inform the patient about the procedure. ABCs, DEF, that's education. So our top one here was a safety issue. Then we had feelings, we had education, and we had implementation. So if we go back to our ABCs, DEF, as a safety issue, this becomes the most important one, and we should select number 1 to verify the physician's order, make sure our patient is safe before all else. All right, example number 2, a patient is receiving oxygen by nasal cannula. After morning care, the patient experiences dyspnea and complains of feeling tired. When planning for the patient's bath the next day, the nurse should plan to give a complete bed bath quickly, bathe only the body parts that need bathing, arrange for several rest periods during morning care, or continue with the same plan of care because we don't care if our patient dies of dyspnea, because dyspnea is unavoidable. All right, so let's look at the question here. When planning for the patient's bath the next day, the nurse should plan to. So this is really testing us on our nursing process. So remember, we're talking ADPIE, assess, diagnose, plan, implement, and evaluate. Which phase of the nursing process is this testing us on? What patient is receiving, the patient experiences dyspnea, feeling tired. When planning for the patient's bath the next day, the nurse should plan to. So we're in the planning phase. This wants to know, do we understand everything that's involved with the planning phase? Give a complete bed bath quickly. That's kind of implementation. Bathe only body parts that need bathing. Also implementation. Arrange for several rest periods during morning care. Arrange, that sounds like planning to me. Continue with the same plan. Well, that's not even a safe thing. So we can cross that one off immediately because our patient's not going to be safe. So option 3 immediately goes back into plan and planning. And we would select that option because it is during the planning phase of the nursing process. All right, let's do one more example. How can the nurse best improve circulation when giving a patient a bath? Apply soap to the washcloth. Keep the patient covered. Use only hot water. Use firm strokes. What immediately stands out to you in this question? The word only should stand out to you. If you remember, we talked about these absolute words, always, never, none, all, every, only applies there as well. We can cross out option 3. So immediately we went from a 25% chance of getting it right to 33% chance just by crossing out this absolute word. Now, apply soap to the washcloth. That obviously doesn't improve circulation. Keeping the patient covered and using firm strokes. Now we're at a 50-50 chance of getting this question right. Now, the correct answer would be using firm strokes, helping with the circulation, helping the blood pump, and that's going to be the best way that we can improve circulation in our patient. All right, guys, that is all the practice questions that I have for you to quickly apply these strategies and these tips that we discussed today. If you guys want additional help, please head over to nrsng.com. We've got 6,000 practice questions with the most detailed rationales on the planet. You guys can achieve this. You guys can do this. You're going to become a nurse. And as always, like we always say here at NRSNG, go out and be your best selves today. Happy nursing. When we talk about objective versus subjective data, what we're doing is we're talking about how we assess our patient. Okay, so we need to understand the difference between objective data and subjective data. First of all, when we talk about objective data, we're talking about things that we can see. Okay, we're talking about our five senses. Can we hear it? Can we see it? Can we taste it? Hopefully we're not tasting it if we're talking about nursing care. These are things that we can see with our five senses. So with these types of things, we're talking about our vital signs, respirations, blood pressure, heart rate. We might be talking about a wound appearance. We might be talking about how the patient ambulates. Things that we can actually physically see on a monitor, on our patient. That's objective data, things that we can observe. Now, where we can get a bit confused is when we talk about subjective data. Subjective data, we gather it from what the patient tells us. Does the subject tell us something? If the subject, being the patient, tells us something, then that's subjective data. We can't gather it from our own personal five senses. So what a lot of nurses and nursing students do is they get in trouble in thinking that pain is objective, where pain is actually a subjective data point. Now, the patient is telling us what their pain is, so the subject is telling us their pain. It's not one of our five senses. That makes it subjective data. So when you're making out your nursing assessment or when you're answering a question, ask yourself, is this something that I can sense with one of my five senses? If I can't, it's subjective data. Is this something the patient tells me? Is this a feeling? Is this pain? Is this what the patient is telling me about themselves? That would make it subjective data. Can we verify the information with a monitor, with our eyes, with our ears? Then it's objective. So objective data, we can see it, we can feel it, we can taste it, five senses. That was 10. Subjective data, that's something that the patient tells us about themselves. The subject is telling us. Objective, five senses. Subjective, subject is telling us. That's what you need to know from it. It's really that simple. Get out there and crush your next exam, crush your next clinical, because now you can tell the difference. We are located just north of Dallas, in a little town north of Dallas, and it's a nice day here. It's actually been not as warm as it can be here in Dallas in July, so I'm pretty excited. It's actually been pretty decent weather here in Dallas in the 90s. Still hot, but not deadly. Scotty, hey, how's things? Scotty, is this Scotty from Kentucky? We got Frank here. We got Amber from Aurora, that's hard to say, Aurora, Maine. Alina from Bakersfield. Nice. Nope, Scotty from Alberta. Sweet. We got Brian from Atlanta. Elaine, Arizona. Seattle. Nice. I love Seattle. Seattle's one of my favorite places. I like to go up there whenever I can. Cool. California. Cool. We got people from all over. Nice. We got some Canadians, got a bunch of people from US, from Atlanta, from New York, California, Seattle, Arizona. Awesome. Good. We got a good group of people. Tara from New Jersey. Awesome. You guys, my name is, all right, we got some Dallas people. Bay Area. Love the Bay Area. My wife is from Bay Area. She's from San Jose growing up. Cool, guys. My name is John Hawes. I am the founder of NRSNG, and I lead this team of nurse renegades working to help you guys succeed in nursing school, pass the NCLEX, and move on and have incredibly successful careers as nurses. So thanks for joining me today. Thanks for taking 30 minutes out of your day to spend some time with me and talk about SATA questions. I'm excited for this. So we're going to run through this. I'm going to give you an example of a SATA question, and then I'm going to answer some of your questions. Now, the method that I'm going to give you to tackle SATA questions is actually very simple. It's a massively oversimplified method, but if you use this when you approach a SATA question on an exam or on the NCLEX, it's going to help you, and it's going to help increase your chances of getting that right. Now, there's a couple things to keep in mind when you take select all that apply or SATA questions. It's that you don't get partial credit, okay? You can get all of them right but one, and you do not get partial credit on the NCLEX. So you must get every single question right or every single answer correct, whether right or wrong, in order to get any credit for that question, okay? The other thing to keep in mind when taking NCLEX is that you can have anywhere from 1 to all of the answer options be correct. So if you're taking a question, NCLEX question on NCLEX, realize that one of them might be right, up to all of them might be right. And you can have as many as 5, 6 answer options, and it doesn't mean that because it's a SATA question that 2 of them have to be correct. It might just be one of them that's correct. So don't overthink that if you see that one's right and you don't think the others are correct, that's okay. And realize that all of them can be correct as well. So if you're working through a SATA question, realize that all of them can be correct. All right. So how many of you guys are in nursing school versus how many of you are preparing for NCLEX? Amber's in nursing school. In school NCLEX. Wow, okay. Prepping for NCLEX. Cool. Awesome, good. So it's a pretty good mix here. We got about half in school and half preparing for NCLEX. This is going to help you regardless of where you're at in your nursing journey. Whether you're just about to take the NCLEX, this is going to help you as you approach those SATA questions on the NCLEX. And this is also going to help you in school get a little bit of clarity as you take these SATA questions. So SATA, again, stands for Select All That Apply. The method that I teach people whenever they see a SATA question is something called the SATA Success Pyramid. If you have some notes, if you have your phone, this is what I would take a note of. Screen is black. Is screen black for everybody? No? Okay. Good. I'll just keep going, and hopefully your screen pops back on. Yeah, I would switch to Mozilla works really well, and Chrome generally works for most people. So what we teach people, guys, is we teach what's called the SATA Success Pyramid. If you want to review this later, go into the test-taking course and review the SATA module in there. So the SATA Success Pyramid is made up of 3 tiers. And this is what you do the second you read a question, and the very last words are, select all that apply. So the minute you read, select all that apply, you engage the SATA Success Pyramid. The first step in this pyramid is you cover all options. I don't have great handwriting, but the first thing that you do, guys, is you cover all the options. So you take your hand physically, or you do whatever you have to do. You cover your eyes, you put blinders on, so that you can't read any of the options. All you can see is the question. Then what you do is you evaluate each answer option individually. So you've got the question, or you've got the answers covered, then you evaluate each answer option individually. You move it down one at a time. So you evaluate answer option A, then you evaluate answer option B, then you evaluate answer option C, and you do this individually. And as you do this, you turn each answer option into a true-false statement. So essentially, all that you're doing with these SATA questions, guys, is you're taking it from this question with multiple answer options that you have to evaluate if they're right or wrong, and you're turning each one into a basic true-false statement. Now, once you do that, you turn each question into a 50% chance of getting it right. So option A is 50%, option B is 50%, option C is 50%. But not only that, what I see a lot of people do, guys, when they see a SATA question is they'll have the question here, and then they got A, B, C, D, E, however many. And what they do is they start trying to associate all the different answer options together. They say, well, A is really close to B, and B is really close to C, and D is kind of the same as A, so it must be right also. So what you really have to do, guys, is you have to cover them up and answer each one individually. Once you've answered whether it's true or false, you move on. Okay, when you move on, you never come back. That's the biggest thing I see people do is they try to tie them all together. Where they say, well, this is a diabetic patient, so it must be right in this patient, and it must be wrong in that patient, and you start trying to build these stories that don't line up. So the minute you read, select all that apply, you cover all the answer options, evaluate each one individually, and as you evaluate it individually, turn each one into a true-false statement. All right? I'm going to try to share my screen here, guys. All right. Can you guys see that? Great. So we're going to read a question, and we're going to practice. So here's the question. A 78-year-old client is recovering from a total hip replacement. Which information would the nurse give to the client that would help to prevent complications associated with surgery? Select all that apply. What is the first thing we need to do according to the SATA success pyramid? We just read select all that apply. What's the first thing we do? Cover all the options. Perfect. Since I'm taking on a computer, what I could do is I can honestly physically use my hand to cover all the options. If I'm not doing that, just make sure that you don't look at the B before you've evaluated A and determined on A. All right, so we cover all the options. What's the next thing we do? Evaluate each one individually as a true-false statement. Perfect. So let's go back to our question, and let's turn this into a true-false statement. All right. True or false, and let me work through this with you guys. I haven't really looked at this question yet. So true or false, after a total hip replacement, the nurse should give the client the following information to avoid complications associated with surgery. Okay, so true or false? After a total hip replacement, the nurse should give the client, or should tell the client, to utilize elastic stockings such as TED hose. True or false? True, 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 true. Great. All right, we all agree on that one. All right. True or false? And we're not going back to A ever again. We're never going back to this one, all right? So we're moving on. And that's, again, the biggest thing that I see people do is they begin to start evaluating each one based on what they answer on the next one. So we're never going back to A again. So true or false? After a total hip replacement, the nurse should tell the client to perform foot and ankle exercises. True or false? True, 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 false. Okay, I'm going to go with the majority. It says true. Okay, true or false? After a total hip replacement, the nurse should teach the patient to use deep breathing exercises twice a day. True or false? False, 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 false. Okay, I'm going with majority here. Majority says false, so I'm not selecting it, and I'm never going back to it no matter what. True or false? After a total hip replacement, the nurse should educate the patient to wash hands every morning and after touching the surgical site. False should be, okay, false, true, true, false. Nice. Elena's pulling out the absolute word one trick we give. All right, so the majority is saying false on wash hands every morning and after the surgical site. All right, again, true or false? After a total hip replacement, the nurse should teach the patient to take all anticoagulant medications as prescribed. True, 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 true. All right, looks like we all agree on that one. Perfect. All right. Should we submit this? We're never going back. I'm not rereading it. I'm not reevaluating. I'm not second guessing myself. Should we submit it? You guys ready? You guys dying? All right, let me submit it. Boom, we got it right. And then we can read our rationale. So let's read our rationale about the washing hands and the deep breathing. Okay. The nurse can teach the client to use proper hand hygiene to avoid infections. Hands should be washed before touching the surgical site. So up here, wash hands every morning and after touching a surgical site. That makes sense. We want to avoid any sort of infection or anything like that. Then it says deep breathing exercises and sensitive spirometry should be done hourly while awake to keep the lungs expanded, which prevents pneumonia. So that's our post-op breathing exercises to help the patient from developing pneumonia. Great. So it's as easy as that, guys. Yeah, so that's one of the reasons why we're going to be doing the anticoagulants, but we need to be doing the foot and ankle exercises as well. Let's see. Because they're going to be immobile because they just had the surgery done on that big hip bone, we want to make sure they're moving that to strengthen it as well. Cool. How do I stop sharing screen? Let me see if I can figure this out. I'm not sure how to stop sharing it. So we'll just keep it sharing from here on out, guys. Cool. Here's what I will do. I can show you inside the Academy where you can learn the rest of our test taking tips and see more about select all that apply questions. Let me see if this is showing up for you guys. Perfect, it is. All right, so you go into the courses and you go into the test taking for nurses. We got some stuff on goals and studying and what is the NCLEX. This one's really, really helpful, guys, because it explains exactly what the NCLEX is and how it uses this computer adaptive testing model. For those of you who are more than a couple weeks out from taking the NCLEX, I would suggest studying this. For those that are closer, maybe don't study it so that it doesn't get you all anxious and nervous. So module 3 is the SATA success pyramid, and I've got it written out there for you guys. And then we've got a link to help you go to these FAQs by the NCSBN, who is the company that administers the NCLEX, so that you can go in there and you can see what these SATA questions are all about. So you can see directly from the source what to expect on SATA questions. Okay. Cool. SATA questions, I think, can be one of the biggest or one of the most scary elements for nursing students. So I want you guys to attack these. I want you to understand that they don't have to be that scary, that there's something that you can overcome, there's something that you can accomplish, and there's something that you can score well on. Don't automatically approach SATA questions as, oh shit, well now I know I'm going to fail this one. Approach them with confidence and just answer each of the questions that you see one at a time. All right? And then as you do that, your chances of getting the question right improve drastically. Then what you can do, guys, is you can come in here to NPQ and you can take a bunch of questions, and as you encounter these SATA questions, just start employing this method and then really focusing on those areas that you're struggling with the most. Man, I wish I could stop sharing so I could. What happens if I do that? Oh, dang it. All right. Sorry, guys. Cool. All right. Who's got the longest streak on their NPQ right here? The highest I ever got was like 5, and then I stopped taking it. I could try that. I got 5, then the weekend comes. Yeah, that's the problem. Alina said, or Frank says, didn't you say SATA indicates the analyzing status of a question according to Bloom's? So, man, I don't, here. Let me go in here and I'll show you guys Bloom's taxonomy so that we can talk about what Frank is asking. So the NCLEX is based on something called Bloom's taxonomy. And essentially what Bloom's taxonomy is it's a method for determining how well someone comprehends something and to what level they really understand something. So it starts at the remember level that, hey, I remember that normal sodium is 135 to 145. Anybody can memorize that. My 8-year-old son can memorize that. He could spout that off, but memorizing normal sodium levels doesn't make somebody a nurse. So then it moves up to the understand level. Well, I understand why sodium is like that. I understand these sodium-potassium pump. I understand membrane potentials and all that. So I understand normal sodium. Then you move up to the apply level, that understanding normal sodium levels and why they're like that, I can start applying that knowledge. And then we get to this analysis level, which is this highest level of comprehending something. That I can look at a patient's data, I can extract that this must be a sodium issue, and I know exactly what to do and how to understand and analyze that. So the question is, are SATA questions generally a measure of if someone understands or if someone's at the analysis level? The short answer for that is not necessarily. The longer answer would be that generally SATA questions are much more complicated questions because they require analyzing multiple different data points, and they require evaluating many different questions or answer options. So if you're getting a lot of SATA questions, it's generally an indication that you're answering more difficult questions and as such doing better, quote unquote, on the exam. Hopefully that makes sense. Okay, Elena says, after I did the test strategy modules, I read that NCLEX focuses on application questions. Am I able to filter questions on NRSNG to mainly answer application level questions? At this time, you're not able to do that. So in NPQ, we don't have it so that you can do it by Bloom's taxonomy at this point. That is something that we obviously, we're tracking. We understand Bloom's taxonomy. We haven't built it in there where you could say, give me only analysis or give me only application or give me only evaluation. So we don't have that availability yet. Sorry. So Brenda says, can you cover answer options during the actual NCLEX exam? So you do have a piece of paper and you do have a hand, or you do have a whiteboard or something and you do have a hand. If you really want to take this to the extreme and actually physically cover it, you could. However, what I really want you guys to take away from covering all answer options is really the idea that once you select, start with A, once you determine true or false for A, don't ever go back to it. Never reevaluate A, move on, because what happens is you decide and you're certain about A, then you move on to B, you're like, oh, well, yeah, but if B's right, then A must be right. So really, it's about making yourself avoid doing that. Scotty, MPQ always has a lot of questions. So MPQ, about 35% of the MPQ questions are SATA questions. So there's a good chance, yeah, probably 1 in every 3 or so questions is going to be a SATA question. On the NCLEX or on the SIMCLEX through NRSNG, it won't, or it will, or it won't be more of SATA questions depending on how you're doing, because it's computer adaptive, just like the NCLEX. So what percentage do we recommend in each category? Amber, I'll get to your question. What percentage do we recommend in each category? We generally recommend you be over 50, 60% in each category on NPQ. Now, there's a couple other things that matter with that too. So for example, I'm 33% on ethical legal, but I've only done 3 questions. So that's not a really good indicator of my actual ability. Neuro, I'm 66%, but I've only done 3 questions, where labs, I'm 87, but I've done 8. So we recommend trying to get all your levels above 50. If you're at 60, even much better. But I think one of the best ways to do it is, if you're currently studying a specific topic in nursing school, create a quiz on that topic. So ear, nose, and throat, for example, and do as many questions as you can and just kind of get an idea of how you rank there. If you're preparing for NCLEX, it's better to do much more broad selection of categories. So you can even do select all, come down here, do 50, and do a couple hundred questions a day even, and then that's going to start giving you feedback on how you're doing in all these categories. Now with endocrine metabolic, I've done 15 questions, but I've only got 20% right. So it'd be really valuable for me to go back into the metabolic endocrine course and take more there. Once I'm doing pretty well there, I can go in and take a SIMCLEX and see how I'm doing just as a SIMCLEX. Yeah, so if you do pop quiz, it's going to do completely random 10 questions. So see, this one's at integumentary from the management of care category. Let's see the next one. And this is why my score's so low. I got that one right. I was going to say that's why my score's so low. So this one's pharmacology. Let's see if we get another. Here's a select all that apply. All right, you guys want to do another one? You guys want to do this one together? I don't want you guys reading ahead. Don't read ahead. Okay, don't read ahead. No one read ahead. That's the rule. If we do this, no one can read ahead. All right, I've said that enough. All right, so a 3-year-old child has diurnal enuresis. Which of the following are effective nursing interventions to decrease the incidence of enuresis? So enuresis, diurnal enuresis, the child is wetting their pants, essentially. So this is a 3-year-old child who's wetting their pants during the day. Which of the following are effective nursing interventions to decrease the incidence of enuresis? So the first thing we do, turn it into a true-false statement. So true or false, restricting dietary fluids, and what we're being asked is, which of the following are effective nursing interventions to decrease the incidence of enuresis? So true or false, restricting dietary fluids is effective at decreasing the incidence of enuresis. Yes or no? False, false, false. Okay. All right. So we're going to skip that one and we're never going back. True or false? Implementing a bedwetting alarm is an effective nursing intervention to decrease the incidence of enuresis. I agree there. Okay. True or false? Implementing a toileting sticker chart is an effective nursing intervention to decrease the incidence of enuresis. True, 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 true. True or false? Encouraging a high fiber diet is an effective nursing intervention to decrease the incidence of enuresis. I agree. I'm having a hard time coming up with a reason for that, which I shouldn't be trying to do. Okay, true or false? Restricting citrus fruits and high sugar foods is an effective nursing intervention to decrease the incidence of enuresis. All right, so we came up with 1 out of 5 as the right answer. This one's a scary one, guys. Even several years out of school, guys, I'm still scared. Oh, whoa. All right. We're going to have to consult Miriam on this one, guys. All right, let's see. Okay, citrus and high sugar foods can irritate the bladder, which worsens enuresis. Darn. Toileting sticker chart can be motivation for a child with successful toileting. We got that one right. And then high fiber diet will prevent constipation, which is a common cause of enuresis. Well, there you go, guys. There you go. Huh. So Peds was not my favorite one, and it looks like I need to go back and watch the Peds. Yeah, because I mean that's what I'm going with, Scotty, is that it's going to relieve some of that pressure probably on the bladder and help. Yeah. So there we go. Here, should we find another one? We need to leave on. We need to get ourselves some confidence here. Let's do another one. Let's find another one. Just skipping through these, looking for a SATA question. See if we get another one. Yeah, you got it right. How often do you guys take NPQ questions? Come on. Here we go. Daily? Cool. Good. Yeah, I think it depends where you're at in your journey. Like if you're preparing for NCLEX, you'd be taking 100, 200 a day. All right, you guys want to take this one together? Sure. All of our confidence is down. All right, don't skip ahead. A student nurse is learning about supraventricular contraction and understands this abnormal rhythm originates in which of the following? Select all that apply. All right. Supraventricular. So true or false? Supraventricular contraction originates in the atria. I agree. Supraventricular contraction, true or false? Supraventricular contraction originates in the AV node. True or false? We got some trues, false, one false, some trues. True or false? SVC originates in the Purkinje fibers. False. True or false? SVC originates in the bundle of His. False. Okay. True or false? SVC originates in the ventricles. All right. Got it. That one we got right. I feel better now that we got one right. We need to beef up that rationale. The supraventricular. So even just going off the anatomy. So one of the tips we give too is going off the anatomy. If you haven't ever seen SVC or seen what it looks like on a EKG graph, just that supraventricular, going back to your med term, means above the ventricles, and then going back to your anatomy, the atria, of course, are above the ventricles, and the atrioventricular node is above the ventricles as well. Yeah, Joanne, exactly. Cool. So yeah, so Karina, how long should you be doing 100 to 200 questions a day? I would do it for 3-4 weeks leading up to the NCLEX. And we have some NCLEX study plans. If you go to the study plans tab inside the Academy, you can do one of the NCLEX study plans, and that'll help as well. Cool. Sweet, guys. Hopefully that helps a little bit. Going back to the basics here. And I was going to show you guys the book I talk about all the time, but the book I talk about all the time is the Test Success book. It's written by Patricia Nugent. It's a really, really great book. You don't need to go buy it. If you, you know, a lot of the tips and stuff we give in the test taking course will help a lot. But if you got an extra couple bucks, it's Prime. Is it still Prime Day? If it's still Prime Day, whatever, head over and there's a book called Test Success: Test Taking Techniques for Beginning Nursing Students. It's by Patricia Nugent. I think it'll help you guys quite a bit. Actually, I guess I can just do this, right? Amazon. So this is the newer version, 27 bucks. I was going to try to find the older version for you guys. You can go in here and try to find the really old version of this book, Test Success by Patricia Nugent. And it's a helpful book. I don't know if she's related to Ted or not. Good question. Yeah. Cool, guys. If you guys need anything, you can always reach out to us. We're always here to help you guys. We want you guys to succeed. That's what we're doing here. That's what everything's about here. I really appreciate you guys taking 30 minutes out of your day to spend a little bit of time with me here in the tutoring. It's always fun to kind of get on here and connect. I wish my camera wasn't out. It feels a little more personal if I can talk to you guys, but we're always here for you guys. Please let us know what we can do to help. There's here, hold on. Inside the Academy for people who are unlimited members, there is a chat bubble here. You can reach out to, right now, Cindy and Kenya are on. You can reach out to them any time of day. Let them know your concerns. And then you can also reach out to the Help Center, the Facebook group, and get a hold of us anytime you guys need. So, sweet guys. I really appreciate you guys taking some time, and I hope you guys have a wonderful day. Happy nursing.
Show of hands, how many people have heard of the SOC method? Sweet. And the reason I ask is because by the time you're all done, you will all know what the SOC method is and how it works. So my first question is, how many of you struggle with pharmacology? Oh, there it is. All right, cool. So I know we just went to lunch, and I know that if I ask you to do this, somebody may go to sleep. But just for a second, I want you to close your eyes and imagine something. So imagine that you have $40 billion. I'm not giving you $40 billion, so don't ask. Tony might. Just kidding. All right, so now I want you to open your eyes and I want you to look. So this right here, this is a house in the area, in the Dallas area. It is a 14,000 square foot house. It's got 8 rooms. It's got 9 bathrooms. It's a 10-car garage that sits on like 5 acres. So if you had $40 billion and you walked in to the realtor, let's say you walk into this house and you say, hey, I want to buy this house. And the realtor says, do you want to finance it or do you want to pay cash? You say, sure, cash. It's like, if you have $40 billion, this house is worth $10.2 million. It's like handing them a $10 bill. So in the grand scheme of things. So this is a Lamborghini worth about $450,000. You walk into a Lamborghini dealership, you've got your $40 billion. You're like, hey, I want to buy that car. And the dealer goes, cool, cash or finance? You're like, cash, cool. It's like 45 cents. I couldn't find a picture of the new Mac that just came out. It's worth about 10 grand. If you had $40 billion, be like a penny, right? So the reason I give you this idea of $40 billion is because $40 billion is actually the amount of money that people spend in the United States to care for patients that have an injury related to a medication error. It's a lot of money. So kind of give you an idea, Bill Gates is worth about $56 billion. So $40 billion, 6,800 prescription medications are available on the market. 7,000 to 9,000 people die per year as a result of medication error in the United States. If we walked into the emergency department and said, hey, what are the top 10 medication errors? Here is the list of those medications. With these red ones, who can, just a show of hands, who can maybe tell me what the significance of the red ones are? Deadly. So if you have a medication, what that means is if you have a medication error and you're working in the ED, you have a 50-50 chance of giving your patient a deadly medication. So why do we think this is? There's a problem. Over the course of your career, you're going to pass out like 172,000 medications. A lot of pills, right? So I want you to look to the person to the right of you and to the left of you. Two of you will say that pharmacology is the hardest subject. Agree? Cool. So if you know me, you know how big of a fan I am of Spider-Man. And there's a phrase that Uncle Ben says, with great power comes great responsibility. The reason I bring this up is because about 70% of the medication errors are actually caught by registered nurses. So you have this fantastic power to catch these medication errors. This number actually comes from during the process of getting a medication from the provider to the patient. There's different phases. In the ordering phase or the writing phase, when the physician or the provider says, I'm going to give this patient metoprolol, they're going to write it wrong half the time. And of that, 70% are caught. So this means that you have this huge, huge responsibility, and you have this great power to actually make your patient safer. So what is this? If this is the problem, then what is the solution? Socks. Cool. Actually, it's the sock method. So this is a method that we came up with. John actually came up with it. It's a mnemonic for learning pharmacology. It improves patient care by doing these three things. It improves patient safety, it improves patient outcomes, and most importantly, it helps you to hone the critical thinking process. As you go through your nursing career, you're going to learn that nursing is not just checking off boxes. There's going to be a critical thinking process, and by utilizing this method, it simplifies the idea of pharmacology so that you guys can get a better understanding of it. So let's go through these. S stands for side effects. You all have this cheat sheet in a small, tiny form. And I want you to take this with you. So S stands for side effects, O stands for organ systems, C actually stands for class considerations and cards, and K stands for know or must know, and we'll get to all these. So let's start with S. So S, when we're talking about side effects of medications, when you look at a medication, you don't need to know everything about the medication. The first thing we're going to start with is the side effects. So if I look at the side effects, if I'm going to give my patient a medication, I need to know what are the life-threatening side effects that I need to know. That's the first thing I need to know. So if I give a medication and it's potentially going to drop their blood pressure, I need to know that, right? The next thing I need to know about are the organs or the organ systems that are affected. So if I give, for instance, if I give a narcotic, who can tell me, just blurt it out, side effects of the narcotic? Perfect. Respiratory depression, where at? Central nervous system. So now we have, what system is that? Neuro. And then in turn it affects what? Respiratory. And if we don't have enough O2, what happens? We die. We have perfusion. We have perfusion issues, right? So now we've hit the top three are our critical organ systems, because we know that that one drug affects all of those in a way. Now there's this other idea of the opposite of the intended effect, which is called a paradoxical effect. So sometimes some drugs like antipsychotics, for maybe your patient is having a psychotic episode and you want to bring them down, you give them some Haldol, well, sometimes it can have the opposite of the intended effect and actually makes them more agitated. So if I know that if I give my patient Haldol that they could potentially become more agitated as a result because it's an opposite of the intended effect, I need to know that. Also want to focus on the key side effects. If I give Tylenol, do I need to know all 500 side effects of it? No. I need to know the big ones, right? And like we talked about with the narcotic, we need to focus on these ABCs, airway, breathing, and circulation. So we know that with that narcotic, we knocked out their breathing drive, and now we know that we have a circulation issue. So even though I don't hit all three ABCs here with the narcotic, I know that I hit those top three. Okay? Next one, organs and organ systems. Good segue. So medication systems can affect one or more organ systems. So we talked about narcotics, right? So we said that narcotics can work on the neuro, it can also work on the respiratory, and then it works on the circulatory center. or the circulation. Who can tell me what is another thing that we need to consider when we're dealing with narcotics that's not life-threatening, but it does affect another organ system? There it is, constipation. Patients need to be on a bowel regimen, right? So we need to know the target system. So we need to know the target system. We need to know that they also, so we know that with the target system, we're talking about the respiratory centers. We know that we want to focus on pain because it's going to work on those cell receptors, but we know that those side effects are going to also affect those organs. We also need to know that it's going to work possibly to make our patient constipated. Now, do I care if the patient's constipated or do I care if they're not breathing? Right. So we need to prioritize when we're talking about organs and organ systems. Okay? Next one. Class considerations and cards. This one's actually broken into 3. So this is the C of the SOC method. So class considerations and cards. So let's start with class. Class is actually broken up into 2 classes. You've got the pharmacologic class and you've got the therapeutic class. If we're looking at a drug, we want to know what the pharmacologic class does because it actually complements the anatomy and physiology. So what is it actually doing in the body? And when we look at the therapeutic classes, how does it help? So who can tell me what Prilosec does? I'm sorry, what? Prilosec, proton pump inhibitor. Yep. So Prilosec is a proton pump inhibitor. That is its pharmacologic class. Therapeutic class, how does it help? Anti-ulcer. Yeah, so with that one, we need to know why, like what it's doing in the body, and then how it helps. So famotidine or Zantac, those are 2 different drugs. One's brand name, one's generic. Those are H2 blockers, H2 agonists. Those are going to be a little bit different. Similar, so like with Prilosec, if we give Prilosec, we know that it is an anti-ulcer. Famotidine is also an anti-ulcer, but they are different pharmacologic classes. So this is where it gets into when we're talking about pharmacologic classes. So famotidine, ranitidine. In the speech that Sandy just gave, you guys got the pharmacology handout. If you look on it, you'll see that there are some, I'm going to look at yours real quick, steal it. If you look at it, it's a prefix suffix. So with those types of drugs, when we're talking about classes, that will actually help you to understand generic names. Lasanzapro, omeprazole, those are proton pump inhibitors. Famotidine, ranitidine, those are H2 blockers. They both do the similar things. Now, let's move on to considerations. When I give a drug, I need to know how to administer it, right? If I get an order for metoprolol, what's a metoprolol? Okay. What do I need to know about metoprolol? Give it what? As far as administer it. If I'm going to give it, should I give it fast or should I give it slow? Slow. Okay. If my patient's in SVT and I have to give adenosine, should I give it fast or should I give it slow? Fast. You slam adenosine. I need to know, so when I'm looking at a drug and I'm trying to understand it, what do I need to know about administering it? Okay? Flomax. Who has given a Flomax to a patient? Nobody's given Flomax? Okay. Flomax is a drug that works on, for patients with benign prostatic hyperplasia. And if you ever open it, it's full of granules, and they're very large granules. Who here has worked with a Dobhoff tube? Dobhoff tube. It's a nasoduodenal tube. So it's smaller than a nasogastric tube. It goes down the nose, into the stomach, and the duodenum. The bores, or the little holes, the fenestrated openings, are very small. You cannot give Flomax in a Dobhoff. It will clog the tube, you have to pull it out, and then you have to drop another one. And it's a pain in the ass. Hate doing it. But nonetheless, these are the things you got to be thinking about when I'm giving my drugs. So if I get an order for Flomax, they're like, hey, it's supposed to go down the Dobhoff. You have to say, excuse me, I can't do this because I'm going to clog the tube. So you have to figure out different things, right? So patient education. What should I think about when I'm educating my patients on, let's say, Lovenox? Who here is given Lovenox? Everybody's given Lovenox, right? Yeah, a lot of Lovenox. Some patients go home on it. We got to show them where to give it. What's the one thing that we need to know about Lovenox when we're giving it every day? Anybody? Alternate sites, right? So that's something I tell my patient if they're going home on the low molecular weight heparin, so that's the Lovenox. I need to make sure that I tell them that you need to alternate sites, because if not. So that's the other thing. Now, this one is really important. So what is vitally important about a medication when I'm learning it? So we talked about the metoprolol. Let's say they're getting metoprolol, and maybe they're on some sort of other blood pressure medicine, and the provider says, hey, you need to give this metop. You say, sure. You look at it, you're like, you know what, that's a really high dose. Hey, we want to give 10 IV, which is kind of high. We're going to give 10 IV. I know that if I give that, I need to make a decision about it. So can I share a brief story with you? When I worked in trauma, I had a patient, self-inflicted gunshot wound, and his heart rate was really high, his blood pressure was really high. So I get an order for labetalol of 20 milligrams. It's a pretty moderate dose, not unheard of. Was a little bit hesitant, and they said, give it. I was like, it's kind of high, can we maybe start lower? No, give it. I'm like, all right. So I gave 5. Labetalol, because it's a beta blocker, you give it slow. As I'm giving it, I'm noticing heart rate come down. Okay, cool. I get to 5. He was at like 110, and he dropped to 90. That's after 5. And I have an order for 20. I'm like, I'm going to go ahead and give the other 5 and see what happens. I hit that second 5, and he dropped to 60. So I had an order for 20. What do you think I did? I called that provider. I said, hey, come here. Come here. You see that number? He goes, yeah. I was like, that's after 10. Like, will you please change the order, because I'm not giving a 20. So the important thing that you need to know about this is be a clinician. Don't just, nursing is not checkboxes. When you get a MAR, you don't just give drugs. You don't just give insulin arbitrarily. You don't give metoprolol. You don't do these things just to complete tasks. It is your job to be scientist, to be detective, to be nurse. You have to do all of these things, and part of that is being a clinician. You guys are working really hard, and I don't want you to make a mistake that will result in a medication error because you just did something, right? So that's what I mean when I say vital information. Cards. So inside the academy, we have these, and we'll make sure somehow we get these to you. I think it's actually on a blog post. These are cards. This is, what I want you to do is I want you to go get a binder. I want you to print out as many of these drug cards as possible. And you are going to practice the drugs you know. Okay? You're going to start with the generic name. We already talked about that. Trade name. So the brand name is another. Pharmacologic class is what it does, and therapeutic class is how it helps. If we want to talk about pharmacodynamics, pharmacokinetics, we're talking about action, why we give that, we're going to fill this whole thing out. You're going to organize them, and then once you think you have them memorized, you're going to throw them away. Did I hear a what? Yeah, exactly. That doesn't make any sense. Guess what? You're going to print more out, and then you're going to rewrite them from memory. We're going to do this. We're going to organize them and study them and rewrite them, and then we're going to start over. And we're going to do this until we know the drugs. Which leads me to my next one, which is know or must know. There are lots of medications, 6,800 medications on the market. Medications are based on needs and research. So if there is a new need, I know that there's probably 5 or 6 on the market H2 agonists. Does the market really need more H2 blockers? Probably not. They're relatively expensive. We've seen that over the course of decades that famotidine and ranitidine do really well for patients. We know about the likelihood of these small side effects, but we don't need to go out and put out a new one, right? So some of these are based on needs and research. The low cost and the low risk ones are the ones going to be used most common. So if you are on a unit and you have a drug like Zantac, Colace, these things are low risk, and you're going to want to familiarize yourself with those drugs. So if you're in an LTAC or a SNF, everybody know what LTAC and SNF are? Okay, long-term acute care facility or a skilled nursing facility, do you need to know about giving an epinephrine drip? No, because it's not applicable to you. It's not that you wouldn't ever give epinephrine, but in that case, it's one that you don't necessarily need to know. If I'm working in OB, do I need to know about oncology drugs? Probably not. So these rare drugs are going to be used in rare cases for small amounts of those cases. Now, Sandy talked about this 80-20 rule, Pareto's principle. And where it applies in pharmacology is that 80% of the drugs are given 20% of the time. And if we flip it, 20% of the drugs are going to be given 80% of the time. So John wrote that book, The 140 Must-Know Meds. I've looked through it, and I've given about 80% of those. So that's where that comes from. So when we talk about know, we need to talk about what we need to know for the unit we're on. And then we also need to know, I don't need to know everything about the drug. I need to know its side effects. And I need to know what organs it affects. And I need to know what class it's in. And I need to know what I need to consider. So we talked about drugs on a unit, right? So if you're in that skilled nursing facility, you don't need to know about the vasodrip. You don't need to know about what they were titrated on a cardine drip. The other reason you need to know this is because your patients rely on the medications that are frequently given on the unit or in your area that you're practicing in, and that you need to know them intimately. They rely on you for their safety. They are trusting you. So when you get done, and the 67% of students who struggle in this area, we want to make sure that when you go out onto that floor, that when you walk onto that med-surg unit or that OB floor or that ICU, that you are well aware of any of the drugs that you give, because our patients rely on them so much. So when I'm looking at a drug, I know that I need to know side effects, organs, class considerations. I need to practice them with the cards, and then there's things that I need to know. But I'm not necessarily going to look at every drug. This is how I remember them, but this is how I actually consider giving them. When I get report, and I'm going maybe from, let's say I'm giving a report, and I'm giving a report from maybe an ICU to the floor, will that nurse that I'm giving report to, will they care that that patient was on epinephrine, on an epi drip, a week ago? Patient's totally stable now? Probably not. We want to flip it. If you're receiving a report and you're on the floor and you're getting an ICU report, and that nurse giving you a report tells you, hey, he was on an epi drip 3 weeks ago. He's stable now. He's about to go home. Probably not important. So when I'm looking at drugs and medications, I need to first look at the organs that are affected. That's the first thing I want to look at. I need to know the target system. I need to know what other systems could be affected. And then, do I need to know this? Do I need to know this for my patient? Do I need to know that they were given some sort of chemotherapy drug once? Probably not. Which means, if I don't, I can scratch the last two off. He was given some sort of chemotherapeutic drug. I need to maybe take it into account, but it's not going to affect the way I'm caring for my patient. But if it's one that I do need to be aware of, okay, cool. I need to know what organs affects. I need to know, what things I need to consider when I'm talking about, do I need to know this med? And then class considerations and cards. All right, cool, I'm on a unit. I need to know these 15 meds because I'm going to give them daily. And then I need to talk about the side effects. So I'm going to work on those life-threatening side effects. I want to look at my ABCs. And I want to look at those 140 must-know meds. I don't need to know all 500. Like I said, no, I don't need to know all 500 of the side effects of Tylenol. I just need to know maybe the first 5, the ones I'm going to see most common, right? So, like we always say, we hope that you guys are having a great time today. We hope that you've learned something. My goal here was that you walked out of here knowing what the SOC method is. We want you to take this and apply it to the way that you learn drugs. There are so many medications. I feel like I got a little bit of a pass because I was actually a vet tech before I was a nurse. I spent about 10 years in the veterinary industry, and there are lots of drugs that you give, and I think about 80% of the drugs that you give in the 80-20 rule, right? About 80% are human drugs that we give to our animal friends. And I got a little bit of a learning, I got a jump start. But when we're dealing with these drugs, we want to make sure that you have a way to learn them, to become intimately aware of them, to know the ones that make sense. And that you don't need to know all of the drugs. It just doesn't make sense. So go out and be your best selves today. And as always, happy nursing.
Hi, I'm super excited to be here today and talk to you all. Some of you might have heard earlier when I was kind of thrown under the bus about being the OB lady, because people don't like OB, I guess. So I created the OB content. I got a few people in here, my scrub nurse up here. So anyways, I'm happy to be up here and talk to you and take you through this journey of being from student nurse to real life nurse and just ways to get through that. All right, so this quote I found I feel really applies. You're gonna pass these boards, you will pass, so you have that success. And then that's not gonna be final, it's just the beginning of the learning journey, the beginning of the process. You might have some bumps along the road as you're going through this journey, but it is not gonna be fatal to you unless you let it. You have to have the courage to continue, and that's gonna be what's important. All right, so you pass boards, now what? I know when I passed boards, I called everybody I knew, right? Because you are shouting it from the rooftops. You might take a good long nap that you've been missing out on all this sleep. And then this isn't gonna last for long because now you're gonna be on this journey. This transition is really hard, becoming from student to real life, but you will get through it. So I'm gonna give you some pointers to get through it. So you're gonna have this reality shock. So let me explain this to you. You in clinical probably had 1 to 2 patients that you were assigned to. I know I don't think I ever had more than 1 patient, which seems super easy when you then go into practice and you have all these patients you're responsible for. You had a teacher with you at clinical, you had peers, you had a real life nurse that was actually in charge of that patient. But when you are the nurse, you are the nurse, so you are in charge. I will tell you, everyone has felt this reality shock, so don't let them tell you that they haven't. 100% they have felt it. So you are not alone. You will start this process, this transition process on the floor, and you aren't gonna have that teacher there. You might not have your nursing school friends to go to, but you have other real nurses there, so you need to utilize them. This process can take 6 months to a year to really get through. So give yourself time, and we'll talk more about that. Okay, so something really crazy that I'm gonna tell you all to remember. So every piece of information that I tell you up here that you learned from me or you've learned from other speakers, I want you to think of one piece of information to one fly. I know that sounds crazy, but at the end it will all make sense. You will see my random fly reminders throughout. All right, so be excited. I was the new nurse, excited coming on the floor. I was with a bunch of tired nurses that had worked there, some for 30 years. So keep that excitement. I wanted to do anything and everything to learn whatever it was, because when I was in clinical, I barely got to put my hands on, IVs, that kind of stuff. So take this opportunity, be excited, and do it. I remember thinking these nurses, I would never have the knowledge that some of these nurses had. I promise one day you'll wake up and suddenly people are coming to you because you are that experienced nurse. And it seems crazy and like it wouldn't happen, but it does. So I remember this seasoned nurse that had worked there for 30 years on my unit telling me that my excitement brought her excitement again. So keep that excitement. It's amazing to have. A plan. So have a plan. So what I mean by this is a plan to stick with, a report sheet. So they just handed out, you guys should have gotten our little NRSNG sample report sheet. Use something like this. It doesn't have to be that, but something to keep your thoughts organized. When you are in this process, your brain is everywhere. You are trying to remember what your preceptor told you yesterday, what happened yesterday with a patient, what you learned in nursing school, whatever it is, you're trying to remember everything. So having some consistency is gonna help. It does not feel good, right, when your brain is all over the place and you're trying to remember. So have a standard report sheet, something you can use so that you can look back at that and just have some organization to your day. Time management is gonna be something you learn to perfect over time. So don't be hard on yourself. It's just a process. I know I have a standard report sheet that I use on all my patients that I take care of. And I take a mini little sticky note and stick it on there, and if they ask me for towels before I leave the room, I write it down because I'm gonna walk out of that room and something else is gonna happen. So it just helps that my mind's not all over and you can just check it off when it's done. So use something like that. Just make a guide or a report sheet that'll work for you. So self-care, we heard the panel mention this a lot. This is really important, and I will tell you, I don't do this. I could be way better at it, but I'm telling you so that you will do it. I work in a nursery most of the time with babies. There's times I don't want to leave the nurses. I don't want to step away, but it is a quick way to burn yourself out, to not take those breaks. Find a buddy, so somebody that can break you for lunch and then you can return the favor. Just step away for 5 minutes. I say this like it's easy. It's not. I'm telling you, I don't do it myself, and I wish I did. So, little story. In the nursery where I work, we take care of drug withdrawal babies a lot. These babies are very hard to take care of. There was this one baby, and I owned her. Like, she was mine every time I came to work. Probably not the smartest thing to do anyways. Got to share that. But I would hold her tight. I could not put her down. This one day she was being weaned off her morphine, and it was a bad day. She cried nonstop. It's that high-pitched, ear-piercing cry. I was afraid to move if I got her quiet. And I remember the night shift nurse coming in, looking at me, and said, "Hand me the baby." I handed her the baby, gave her a report. I got in my car and I cried all the way home. I got home to my family, my husband, my 2 boys, and they needed me. And I had nothing left to give. And I will tell you, you will have days like that. So take a break. If I had just stepped away to the bathroom, I don't think I went to the bathroom today. I don't think I ate anything. I stayed right there. And you're gonna have patients that you don't wanna leave and you're afraid to step away from. But it is important to take care of yourself. A tired, burned out nurse cannot take care of a patient as well as a nurse that has gone to the bathroom, had a bite to eat, even if it's a piece of chocolate back in the back of the nursery or wherever you're working. So take time to take care of yourself. It's very important. When you are the nurse, you have to schedule yourself these little breaks. So going back to that report sheet, when you've organized your thoughts, try to schedule time in for yourself just to take a moment. It's okay. Your patients are gonna want you to be able to take good care of them. Okay, a mentor. So this is really, really, really important. A mentor can be anybody that has worked on that unit that can kind of help you. Some facilities, hospitals are awesome and they will give you a mentor. They'll assign you one. So use them. You can have those scary conversations with them. They can be that scary doctor on the other end of the phone and you can practice. You can go to them and just ask questions. Have a mentor. You might be assigned one that you don't jive with. Find another. It's okay. So utilize them. They can really help you and help with that reality adjustment because, again, everyone has been through this. Delegate. This is also hard. So especially if you've been a tech working on the unit or whatever it's called in your facility, and then you become a nurse on that unit because now you were doing this role and now you're doing this new role. So delegate. It will allow you to focus on your new role as a nurse. So don't feel bad about giving them other tasks and letting them take that on. When I was a new nurse, I thought I could do it all. I thought I could do the morning bath, I can do this. I quickly failed, so I'm telling you, just delegate and don't do what I did so that you can focus on that new role. All right, so you probably hear us talk about this a lot too, your why. So remember your why. Why are you becoming a nurse? Why are you about to take boards and be a nurse? Why are you just starting on this journey? I want you all to close your eyes, I know I'm one of those people, and just think for a moment what your why is. So maybe it's to take better care of like family member than what you've seen them be taken care of. Maybe it is just because you like to take care of people. Maybe you like blood, maybe you like wounds, or whatever it is, or babies being born. Whatever it is, that's your why. And you need to remember that. Because at times you will forget, at times you will lose sight of your why. So take time on those hard days to remember what started you on this journey to begin with. This transition, so it's not easy, it's completely unavoidable. You are going to learn from every change you go through, the transitions you might question that why. So remember why you started on the journey. There's days you'll have nothing left to give, as you heard me say. I've had that too, but don't stop, keep going. So the cool thing is every change, every transition, it has a start and it has an end. So you just have to keep moving and get through it. Or Finding Nemo fans, you just keep swimming, right? Just keep swimming. So you get to the other side. Sometimes after you get through this, you are going to be so glad. You're going to look back and see all the wonderful things that you learned on this little journey. Goals. So I want you all to have some goals. This is going to give you drive. It's going to give you excitement, like I talked about. That's super important, that drive and excitement. One day your goal might be to have an assessment charted by 9 a.m. It's cool. That's your goal. It might be to have a crucial conversation. It might be to advocate better for yourself or for your patient. Whatever it is, that's your goal. So have it. It's going to give you drive, focus, that excitement that I talked about that's so important. You might one day have a goal to go back to school. I know probably all of you are like, never again, and I've been there. I had a biology degree, and what was I going to do with that? I did not like teaching. I thought I never would, and now I love it. So I went back to school, and I became a nurse, and then I went back and got my bachelor's, master's, and a certification along the way. So never say never. At least I learned I can never tell myself never. So if you have a basic goal, you're only ever going to achieve that, right? So set a high goal, and then you'll fall either there or somewhere just under it. But you put a big goal and try to achieve that. And be proud. I want you all to keep this proud. Be proud of yourself. Wherever you are on this journey, or if you're just starting it, be proud of what you've achieved and what you will continue to achieve and accomplish. So you might not get that IV every time. You might miss something along the way on an assessment. It's okay. So don't be hard on yourself. So I'll tell you guys a little story. This is where I'm probably going to cry. I showed up to work, mine as well, everybody else has. Showed up to work one night, and I was fresh-ish off orientation. It was a busy med-surg floor is where I started, and we had 4 hospice beds. I was in charge of one of the hospice patients and a bunch of others. So I was tired because it was night shift. You don't sleep well, or I didn't sleep well. My brain was tired. It was my last night of the week. I had a preceptor, an awesome preceptor that gave me extra reading material to take home. And he continued to do that even after I was already on my own. Like, he did not leave me alone. Here's some more reading material. Maybe I needed it. So I was exhausted, and my brain was everywhere. So I had just been kind of snapped at by the doctor for the first time, and because I had to call and wake him up. And I thought, okay, I'm not going to cry, and you're trying to hold it back, which makes it worse. So I snuck into my hospice patient's room, who had been unconscious 4 days. So I go in there, and I think, this is safe. If I cry, it's okay. Okay, wouldn't you know that that man decided he was going to talk. And he said, "She is proud of you." And I went closer to him, and he said it again, "She is proud of you." My grandmother had died shortly before I started nursing school. That lady, every time I talked to her, said, "I'm proud of you, be proud of yourself." She always wanted me to know. In that moment, I felt she was there. Instant goosebumps, right? She was reminding me of my why I started on this journey, and just to keep going. I will tell you, that night when I came in, I was questioning, what have I gotten myself into? Which is not a good feeling to have when your family is ready for you to go be professional, right? So in that moment, my unconscious hospice patient pulled through and told me just to keep going. Okay, so this is some helpful advice that I talked to new grads, I talked to some of our nurses, that was kind of information that they felt was helpful to them, or that they wish they had thought of. So, learn policies. This is not something that NRS&G can teach you. It's not something that your school can even teach you really, because every facility has their own. So even if you just do one a day, whatever it is, to make you more confident, that is going to help give you confidence if you know how to take care of the patient you're taking care of because you know the policy around whatever it is they have going on. So get familiar. If you have an awesome preceptor like me, you'll be handed a stack of policies to keep reading. And then know where to go for information. So this could be frequent phone numbers that you have to call, like other units, lab, pharmacy, you're always got to bug them. Just write it on a Post-it, stick it behind your badge. That way, in that moment, you can quickly find what you got to call instead of being like, oh, where's that list? Where's the number? So just know where to go for information. Practice communication. People ask me all the time about this. There's no way to get better at it or make it easier unless you do it enough. And then you're going to be talking to the doctors like it's nothing. But practice those conversations if that is something that stresses you. And don't be hard on yourself. Please, if you take anything away from this today, do not be hard on yourself. Give yourself a break. No one steps on a floor and knows everything that they're supposed to know. I still step on my floor and learn things, and that's a good thing. If somebody shows up and thinks they know everything, then they probably shouldn't be there. So you are not going to know everything, and that's expected. You are there to learn. This is when the real learning starts, when you get to this point. 10 years later, I still am learning. So give yourself a break. Give yourself time. All right, so our little quote here. I will say no one will tell you this journey is easy, but everyone would say it's 100% worth it. You just have to keep going and get through it. And you are going to do great things. All right, so why the fly? Okay. So remember, I said one fly was to one piece of information. So these flies are going to stick with you. Every time you learn something at school, here, from any of us, from your teachers, it is going to stick with you. You will carry these flies with you on all your journeys. They will help you do better next time. They will improve your practice, give you confidence, whatever it is. You will start with a few, maybe, and then by the end, you will be covered in flies. 10 years later, even more flies. Okay, so keep that visual in your mind. Those flies will help you. All right, so some key points to recap here. Be excited. You all are awesome. You're going to do awesome things. Remember to keep that excitement with you because it's contagious. You want other people to feel that again. Those tired nurses need to feel that again. Have a plan so that you're organized. So if it's a report sheet, whatever it is, just lay out your day and have a plan. Take care of yourself, please. I'm still working on this. But take care of yourself. Attempt to have those breaks. Ask for help. Mentors. So they're there for asking questions. If it's somebody at NRS&G in a tutoring session that you just want to ask a question, something you've seen, we're here for you. Find a mentor on the floor that you can ask questions to. And pick their brain and get those flies from them. Get the information from them. And delegate. So don't be afraid to delegate. Use them so that you can get good in your new role. You are now moving on to your next step. So delegate tasks so that you can really focus on you in this journey. And happy nursing.
All right, guys. So as y'all jump in the comments if you're in the chat and let me know you're here. And we'll get started in 30 seconds or so. Give people a chance to jump on. All right. Okay. All right, guys. So we are going to talk about dimensional analysis. So, hi, Sarah. So dimensional analysis is a method for doing dosage calculation. And in my personal opinion, it is the method for doing dosage calculation. A lot of times you'll learn like different formulas depending on the different types of questions that you're doing or different things that you're looking for. You'll have a different formula every time. And so then you have to remember which formula to use and what's different about it. And I just don't like that. I think it's too confusing and it leads you down too many different roads. Hey, Chris. So I like dimensional analysis. The biggest benefit of dimensional analysis is that you do it the same way every single time, and you end up with one calculation, not multiple. Okay, all your conversions are included in the same place. Everything is in one place, so you don't have to worry about remembering different formulas or converting and when do you round. One calculation. So I love dimensional analysis for that reason. So what I'm going to do is I'm going to give you the 5 steps to dimensional analysis. We're going to work a couple of problems together, and then if you guys have questions or if you have other problems you want me to work out, we will do it. Okay, so I want you guys to be ready to write this down because these are your major steps to dimensional analysis, and you're going to do it this way every single time, okay? So step number 1, and I'm just going to go through these so you can write them down, and then we will actually talk about, excuse me, I have the hiccups, y'all. We'll actually talk about what they mean as we go through the practice problems. So first thing, step 1 is always start with what you're looking for. Start with what you're looking for. And you'll see what that means when we work it out, okay? Start with what you're looking for. Number 2 is transfer your units across or up. Across or up. And again, you'll see what that means when we do the thing. So start with what you're looking for. Transfer your units across or up. Insert what you know or convert if you don't. So insert what you know or convert if you don't. Insert known or convert, okay? Now, step 4 is easy. It's just repeat 2 and 3, right? Insert what you know, convert if you don't. Transfer your units across or up. Insert what you know, convert if you don't. Transfer your units across or up. So how do we know when we're done? We're going to do that, and you're going to cancel your units until you get your desired result. And again, your desired result is what you're looking for, right? So cancel your units until you get your desired result. Once you get your desired result of units at the end, then you're going to multiply across the top, divide across the bottom, and do that all in one calculation. All right, so I'm going to hold this here for just a second. Take a screenshot if you need to, write it down, have these steps in front of you as we work out our problems. Okay? All right, so let's work out a couple problems. The beauty of dimensional analysis, again, is that you can do it the same way for every type of problem. So we're going to go from really simple to more complicated, okay? And then if there's another type of question or another question you guys have that you want me to work out, let me know, okay? So the very first one is the provider orders 650 milligrams of acetaminophen. So I'm just going to write O, right? O is your order, 650 milligrams of acetaminophen. Available on hand is 325 milligram tablets. So then the question is, how many tabs do you give per dose? Okay, so there's our first problem. The order is 650 milligrams of acetaminophen. The available form is 325 milligram tablets. How many tabs are we going to give? Okay, so step 1, start with what you're looking for, okay? So what are we looking for in this case? What are we looking for? What units? Tablets, exactly, tabs. And you can even, if you want to just be really clear, you can say tabs per dose, because that's what you're asking, right? How many tabs are you going to give in this dose? So you start with what you're looking for and write that down on the far left. And then you're going to put a little equal sign. Okay, so this is step 1. Step 1, start with what you're looking for. Okay? So step 2 is transfer units across or up. So in this case, we're going across. So we're going to take these tabs and transfer them over. That's it. That's all we did. Transferred over tabs. Okay? So now the question is, so step 2 was transfer units. Step 3 is insert what you know, convert if you don't. What do we know about tabs or tablets? What do we know? We know that 1 tab is how much? Yeah, 325 milligrams. So we know 1 tab is 325 milligrams. Sorry, I like colors, y'all. So we know that 1 tab is 325 milligrams, right? So step 1 was start with what we know. Step 2 was transfer units across. Step 3 was insert what we know or convert if we don't. Step 4 is repeat steps 2 and 3, right? So step 2 is transfer your units across or up. So in this case, we're going to transfer our units up to the next line. Okay, so transfer our units. The next step, repeating step 3, insert what you know or convert if you don't. What do we know? What other information do we know about milligrams? So we've already used this one. Yes, our order is for 650 milligrams per dose, right? In 1 dose is 650 milligrams. Okay? So we transferred our units, we inserted what we knew. Remember, our goal here is to cancel our units as we go. So anytime you have the same unit on the bottom and on the top, you're going to cancel it. So look, I've got milligrams here, so I can actually cancel those out, right? So the goal now is to cancel units until I've achieved my desired result. Well, this is my desired result, right? And so I've got tabs here, I've got dose here, I've got what I want, right? I've got tabs on the top, dose on the bottom, everything else is canceled. So now I can move on to step 5. Step 5 is multiply across the top, divide across the bottom. Now, when I do this, this is all going to go in your calculator as one calculation, okay? Don't leave out your ones. Your ones will help you stay on track, right? So this is going to go in my calculator like this. 1 times 650. Okay, so I multiplied across the top. Now I'm going to divide across the bottom. Divided by 325 divided by 1. Again, multiplying and dividing by 1 doesn't change your calculation, but it helps you stay on track, make sure you included everything, right? So I multiply across the top, divide across the bottom, all in one calculation. Put that in my calculator, and what do I get? This is the easy part, y'all. 1 times 650 divided by 325 divided by 1, 2. And what are my units? Tabs, or tabs per dose. So even for these really simple problems, you can use dimensional analysis, which is nice. Questions about this one? What we're going to do now is we're going to do, correct, Sarah. So by doing this in one calculation, Sarah said, we divide across the bottom, not multiply? Yes, because we're doing it in one calculation. What some people will do is they'll multiply the top, they'll multiply the bottom, and then they'll divide them. I don't like that. That's multiple calculations. I don't want you to have to do that. By going this times this divided by this, you got one calculation, you got everything. Cool? All right, so what we're going to do now is we're actually going to do a little bit of a more complicated problem, a couple extra variables. But what it's going to allow us to see is how not only can we use this for the really simple problems, we can actually use it for the more complicated problems as well. All right, so our second problem is the provider orders 60 milliequivalents of potassium chloride, IV, to be given over 4 hours. Okay, so that's my order. 60 milliequivalents of potassium chloride IV to be given over 4 hours. Okay, my available on hand is 100 milliequivalents of potassium chloride in 1 liter of normal saline. Okay, so order 60 milliequivalents over 4 hours, available 100 milliequivalents in 1 liter of NS. The question says, what rate do you set the IV pump at? So here's a pop quiz for you guys. What units are we looking for if we're looking for an IV pump rate? Yeah, milliliters per hour. Now, in some like syringe pumps and NICUs, things like that, you might actually program milliliters per minute, but it's pretty rare. 9 times out of 10, when we're looking for a rate on the pump, we're looking for milliliters per hour. So step 1, start with what you're looking for. So all the way to the left, I'm going to write milliliters per hour equals. Okay, that's my very first step. So that's what I'm looking for. Step 2 is transfer your units across or up. In this case, we're going to go across and we're going to put milliliters. Okay. Now, the next step, step 3, is insert what you know, convert if you don't. Is there anything in our question that we know about milliliters specifically? Do we see milliliters up here anywhere? We don't, right? Nope. But what do we see? Yeah, we see that liter. So insert what you know or convert if you don't. So we need to convert these milliliters to liters. So you guys got it right there. There's 1,000 milliliters in 1 liter. Now I will tell you guys, I highly recommend you leave whole numbers here. Don't do like 1 milliliter is 0.001 liters. You're going to get your brain all mixed up. So 1,000 to 1 is way easier to do than the other way around. Okay. So 1,000 milliliters in 1 liter. Perfect. So the next step is transfer our units, in this case, up. Okay. And now we can say, what do we, so we've transferred units, insert what you know, convert if you don't. What do we know about liters? Now we have something, right? What do we know about this 1 liter here? That 1 liter has, yep, 1,000 milliequivalents. I'm sorry, 100 milliequivalents of potassium chloride. Now, before we move on, remember the whole goal here is to cancel our units till we get what we need, right? We've got liters here, we've got liters here. Let's go ahead and cross them off. Are we where we need to be yet? Not quite. We still need hours, right? So I'm going to take these milliequivalents. I'm going to go back to step 2 and I'm going to transfer my units up. So now I have milliequivalents. So what other information do we have about our milliequivalents? We've already used the 100. So what else do we know about milliequivalents? I'll give you a hint. It's right here. Yeah, wanted is 60 milliequivalents. And what do we know about that 60 milliequivalents? 60 milliequivalents over 4 hours, right? Do you guys see that? That is what is associated with that 60 milliequivalents. So 60 over 4 hours. You're not slow. I'm fast. It's all good. All right. So again, our whole goal here is to get to the units we want. Okay. And so we have milliequivalents on the bottom and the top. So we're going to cross them out. So have we gotten where we wanted to be yet? We've got milliliters here. We've got hours here. And that's exactly what we wanted, right? So we're good. So now we can move on to step 5, which is multiply across the top, divide across the bottom. I'll write this one out because I still only have a few. The next one I won't be able to write out. So 1,000 times 1. Again, I leave my ones in because it just helps me place hold, right? Make sure I don't miss anything. times 60 divided by 1 divided by 100 divided by 4. All of that in your calculator at one time. 1,000 times 1 times 60 divided by 1 divided by 100 divided by 4. And what do you guys come up with? What'd y'all get when you put that in your calculator? Yeah, 150 milliliters per hour. Now, anytime you do dosage calculation of any kind, always go back and ask yourself if it makes sense. So if you had ended up with like 300 milliliters an hour, you'd be like, wait a minute, that entire liter is going to be gone in 3 hours, right? And that's way too much. So always kind of ask yourself if it makes sense. All right. So again, even as we get more complicated, even as we have conversions, even as we have more variables, dimensional analysis still works. And that's why I like it. That's why I like it. All right, questions about this one before we move on to an even more complicated one? All right. So again, multiple variables, multiple conversions, we can do all of it. All right, so ready. Your patient has dopamine infusing at 39.3 milliliters per hour. So that's the first thing we know. Dopamine is infusing at 39.3 milliliters per hour. Our bag of dopamine has 400 milligrams, sorry, I'm like blocking my face, 400 milligrams in 250 milliliters. Okay. My patient weighs 192 pounds. Okay. So the question is, what's the dose they're receiving? Well, in dopamine, we want to know how many micrograms per kilogram per minute they are receiving. Okay. That's the standard kind of way we dose dopamine, mics per kilo per minute. So step one is always start with what you're looking for. Now, here's the trick you need to learn. Anytime you have extra pers per kilo per minute, they both go on bottom, okay? So we're going to go micrograms on top, and then we're going to go kilograms per minute on bottom, okay? If you have a double per, they both go on the bottom. Fair? Y'all get that? Because that's really big. We're going to see that here in a second. It's going to be important, okay? So step one, start with what you're looking for. Sarah, whoa. Do you need me to say it again? Stop me. Feel free to. Okay. Okay. She said, nope, don't stop. Just cool. So micrograms on top, kilos per minute on the bottom. Okay. So step one. Step two, transfer your units. So we're going to transfer our micrograms over. Step three, insert what you know, convert if you don't. Do we know anything about micrograms, or do we need to convert something? Do I know anything? So Christopher, look, 400 milligrams. 400 milligrams. Yep, so we need to convert, right? So just take your time, right? There's no rush. So how many micrograms in 1 milligram? We're going to convert micrograms to milligrams. How many micrograms in 1 milligram? Yeah, 1,000. Again, always do 1,000 to 1. Don't do the 0.00. That's too much. So 1,000 micrograms in 1 milligram. Then we're going to transfer our units up, milligrams, and we already pointed it out. What do we know about milligrams? There's 400 of them, right? And how many? 400 of those milligrams in what? 400 milligrams in, you'll see it. Yeah, 250 milliliters. All right. I love the colors, you guys. I get a little crazy. So again, our whole goal is to cancel our units till we get to what we want. So since we have milligrams on the bottom, milligrams on the top, we're just going to cross them off. We don't need them anymore. We're not where we need to be yet, so we're going to have to keep going. So we're going to transfer that unit up, and we're going to put milliliters on top. So now, what else do we know about milliliters? We've already used this one, so we can't use that one anymore. So what else do we know about milliliters? Yeah, 39.3. So 39.3 milliliters in what? What is the 39.3 milliliters associated with? 1 hour, exactly. So see how you see the things that are associated with each other, right? 1 hour. So again, milliliters on the bottom, milliliters on the top, cross them off. All right, so now we're at hours. Are we where we need to be yet? We don't need hours, do we? What do we need? We need minutes instead, right? So I'm going to transfer my hours up to the top. Sorry, I know this is going on 2 lines, but that's okay. So I'm going to transfer my hours up to the top, and I'm trying to get to minutes, right? So if I'm trying to get to minutes, I know 1 hour is how many minutes? This is the easy one, guys. Look at me. 1 hour is 60 minutes, exactly. All right, so I can cross off my hours because I have hours there and hours there. So I've got my micrograms. I've got my minutes. What am I still missing? What am I still missing in my problem? Yeah, my kilograms. Okay, so here's the part where I'm going to slightly blow your mind, and that's okay. That's okay. We need kilograms, right? And we need it on the bottom, don't we? Because that's where we put it because we had our double per. So we need kilograms and we need it on the bottom. So we're going to put it there. And then we're going to do what we got to do with it, right? So do we know anything about kilograms up here? Nope. We need to convert. So what's my conversion? What's my conversion from kilograms to pounds? Yeah, 1 kilogram is 2.2 pounds. So I have to make sure all of my units canceled, right? So how am I going to get these pounds to cancel? I need another pounds on the bottom, right? Because otherwise I have microgram pounds per kilo minute, right? Which is crazy. So got to get my pounds to cancel. So what do I know about pounds that I can get rid of? Yeah, my patient weighs 192 pounds. Now this is the part, like I said, sometimes this blows people's minds, but if you just need to put an imaginary 1 in here, that's fine, okay? Just an imaginary 1, it's just a placeholder. But now we've got our pounds and our pounds, and we can cancel those out. Now we've got our kilos on the bottom, micrograms per kilo per minute, and we're ready to go. Sarah's mind is blown. I love it. I love it. So really, we did a calculation for the rate, and then we realized it was weight-based, and so we added the weight part. Basically what we did. So we've got everything we need. We've gotten to the units we were looking for, and now we can put it in our calculator. So I'm not going to write it out this time. I'm just going to draw. So we're multiplying across the top, and we have our top comes down here, right? So we're going to go in your calculator. Ready? 1,000 times 400 times 39.3 times 1 times 2.2 times your imaginary 1. Okay, divided by 1, divided by 250, divided by 1, divided by 60, divided by 1, divided by 192. Okay, so multiply everything across the top and then divide, 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 divide across the bottom. One calculation in your calculator. What do you come up with? Yeah, so your calculator will say 12.00833333. In our pumps, we only go to the tenths place. So if you round to the nearest tenths place for your pump, you're just going to end up with 12 milliliters per hour. or I'm sorry, 12 micrograms per kilo. That was me. That was me, guys. 12 micrograms per kilogram per minute. We typically only go to the 10th place. So it would be 12.0. So 12 mics per kilo per minute will end you up at 39.3 milliliters per hour. Okay, so that one's a little more complex, has a lot more variables, lots of conversions that we have to do, the double per on the bottom. But do you see how we can do dimensional analysis for the super easy acetaminophen problem and all the way through these weight-based problems that you have, okay? So what questions, Sarah, you are so excited and it's making me so excited. I love it. What questions can I answer? Is there another type of problem that you're not sure about? Questions about dimensional analysis, anything. Dosage calc. I just love math. I'm kind of a nerd. Math is fun. But honestly, that's one thing I love about dimensional analysis is it doesn't really require a lot of math knowledge and thought. It just requires knowing how to set it up. So again, start with what you are looking for, transfer your units, insert what you know, convert if you don't, and repeat those two things until you cancel out everything but what you need. And then you just do your math in the calculator. It does, absolutely. And so I'm going to send you guys a link really fast. There is a, sorry, I didn't have this open and I usually do, so this is my fault, guys. There is a lesson on dimensional analysis where I actually work through the same 3 problems, but you'll be able to see me talk through it in the same way that I talked through it just now. And in there, there's also a, there's also a cheat sheet on dimensional analysis with problems actually worked out in the dimensional analysis format. So you can see the way it's set up, you can see the order in which I went through, and I'll actually give you a link to the library so that you can get that cheat sheet as well. So for those of you who are not in chat or don't have access to the library, if you go to the pharmacology course, go to module 2, lesson 2, it's a dimensional analysis lesson. And inside that lesson, you'll be able to download this cheat sheet that actually will give you, and I'll show you what it looks like. It gives you examples of problems worked out. So there's the actual problems, and then they're actually worked out in dimensional analysis so that you can see, you can even walk through and cross off the units and see where everything's at and see how all of that was worked out. Okay. So any problem that you have, we have a ton of math. If you go to, in fact, what I did, that link to the library is Farm Module 2, the math module, and all the cheat sheets that you can find there. So any problems that you have, use this method to work them out and see how accurate it is. But really just knowing those steps to dimensional analysis and knowing how to set it up, that's really the best thing that you can learn, because then the math itself, the math works itself out, right? Yes. So Chris had said it helps to set it up what you have versus what's available or what your order is. So I almost always write that way. My order, what's going on, you know, my available forms. I just get all my information kind of concisely in one place. You will, in nursing school, not on the NCLEX, maybe on the NCLEX, but very rarely, you will sometimes have information that's extra. So there is sometimes where you have to look and say, okay, do I even need this? Is this actually applicable to what I'm looking for? Is this the right piece of information? So there's some critical thinking involved, but for the most part, if you follow that process, it really helps. It really helps. All right, guys. Any other questions? Yeah, they do. They do. The truth is, guys, I don't like the things that are distractors for the sake of being distractors. But here's the reality. In real clinical practice, you're going to have all that information too, right? You're still going to have to pick which information to use, which numbers to use in the real world. You're going to have lots of numbers coming at you. You're going to have lots of information in the real clinical world. And you do have to be able to pick out which information do I actually need. So this is like the one case, like dosage calc is like the one case where I'm not super against it, because in the real world, you're going to have a lot of extra information too. So, but again, kind of understanding where you're going with things, understanding that you're trying to associate two things so that you can get your units canceled. If you put a number in there, but then you don't have anything to associate it with, or it like doesn't, there's nothing you can say like, oh, that's equivalent to this many hours, or that's equivalent to this many milliliters. It's possibly a piece of extra information. And so making sure that you're actually able to still follow that process is really helpful too. All right. Any other questions, concerns, complaints? Awesome. Well, you guys did awesome. I am going to post, as always, our little survey. Yes, Christopher, practice, practice, practice. It really, really helps. So that library link with all the math cheat sheets, pick any math cheat sheet and any math problem and use this method for it and get really good at this method and you'll be great. I like can't do dosage calc any other way now. All right, guys, so fill out that survey for us. Let us know how we're doing. Let us know what we can do better, especially if you have new ideas or new things you want to see us do sessions on. And we'll try to get that happening for you. All right, guys, have a fabulous day. Go out and be your best selves. And as always, happy nursing.
Okay, so we are going to be talking about confidence in communication. So I did the little communication course that NRS&G has, and as well as the OB course. So, and then we'll tutor on OB and communication. So first, let's start. So to be confident in communication, there's some basic things, but who are people that we communicate as nurses on a daily basis with, or different times that we communicate? Lots of people. Who are they? Doctors, pharmacy. Yes. Oh, I didn't even write pharmacy on my little list over here. That's very true. Pharmacy, doctors, patients, family members. Yes. So lots of different people, lab, physical therapy, of course, the patients, social work. Yes. So you have to know what to communicate in order to be confident. And of course, that's going to kind of vary depending on who you're talking to and about. So just some basics. So who's the scariest for you guys that you think of to talk to have a conversation with? Out of that, yes, to the doctors. I 100% agree. I will tell you that as you practice, which you'll hear me say several times, practice, practice, practice is the only way that communication gets more comfortable and you get more confident. But they are the scariest. But as you practice more and when you're working on a unit, you get to know the doctors. You kind of know what they want to know. They don't want too much information or just the different details that they like. You kind of know what they would order in a certain situation. So when you do that, then you're it's a little bit easier because you know what to expect and it makes it more comfortable. Now I have doctors that come to visit me on the floor when they're walking by because I've worked there so long. So you'll kind of get there. And I know it'll feel like you will never be that confident, but you will. It will definitely just happen. All right, so let me share my screen. Give me just a second. So I pick the right thing here. All right, can you guys see it? Yes, okay, cool. I just want to make sure before I get going. All right, so we've kind of talked about who are the different people we communicate with and who the scariest people, and I think a lot of us agree that the doctors can be pretty scary. So there's a lot of reasons why people might not feel as confident. So let's talk about those different reasons. Because if you know your reason why you don't feel confident, then you can work on overcoming that. So sometimes it's that you're the new nurse, RN or LPN. So just a new nurse on the floor, which is going to be a lot of you all soon. So also a new unit as you move around to different floors, switch jobs, so you're on a new unit. It could also be different language. So I have a funny story for you guys with this different language piece. We have a, you're supposed to use those Sierracom blue phones, you don't use the family as translators, all these rules. Well, one of our nurses was using Google Translate, and I will tell you, Google Translate, you want to put in, what you want to say, and if you don't flip it back, you don't realize that sometimes Google Translate is not so great. So she was trying to tell a family or ask a family when the baby last ate, and she said instead of that, she said she was going to eat the baby. And then when she tried to communicate about doing lab work, that she was going to take the baby to do lab work, she said that she was going to suck the baby's blood. So Google Translate is not the best, although I do love some Google. So different language, that can obviously be a big reason. All right, so those are my reasons, my main reasons that I think people are not or not as confident. So let's look at now as ways that we can be confident. So just some different pointers here. So practice. And I will say practice key phrases that you're going to say a lot. You know, if it's a certain report sheet, like I work in a nursery, so we have a certain report sheet. It's a certain set of things that we communicate between nurses, or when we're giving a report, or to the doctor, like our SBAR. So use that to practice. Oops, forgot my A there. Use that to practice. So practice those key phrases, because you'll get more confident if you're going to be saying them over and over. And then also just practice just talking to one another. So what I mean by that is that you can talk to a nurse and practice the conversation. When I was a new nurse, I had a mentor, and I would just practice these conversations before I picked up the phone. The mentor was my preceptor, but if you practice having those conversations, it just makes it a little bit more confident. So that preceptor of mine was awesome, and he would kind of talk in a mean way to me, and the doctor was way nicer than what he was when he was doing these conversations, but it had me ready so that I knew exactly what I needed to have. So have information in front of you. So don't try to make a phone call to these doctors and not have the chart open in front of you or everything jotted down that you need to say, because you know what's going to happen. It's going to be 2 a.m. and you're going to get flustered. You're going to get off the phone with the doctor and then remember that you forgot to mention something. And that's the worst. And you don't want to call a doctor back or call them at all at 2 in the morning. So have everything you need in front of you. That's important. Another little key pointer I have is observe others. So when you are on the floor working now, so if you aren't a nurse yet and you're working on the floor and you see other nurses talking to doctors or making those calls to the doctors or talking to physical therapy to the other people that we talk to, listen to them and pick up on those pointers. You'll just pick up on things that they're saying and doing, and how they respond. And that will kind of help, because you'll take that in. So all those little pieces of information you'll take with you and be able to put into practice. And then ask others. So those nurses that have been on the floor for a long time, they know what the doctors like to know, what is too much information. They probably know how that doctor is going to respond to something. So ask the other nurses, use them, they're there. So take advantage of that. And my last little huge point here is to listen. So you cannot be confident in what you're saying to someone if you are not listening to what they're saying to you. So if you are constantly thinking of the next thing you're going to say, then you are not really listening to what the patient or doctor or whoever it is saying. And then if they go to ask you a question about that, you're not going to know how to respond because you haven't been listening. So listening is going to help give you confidence, because you'll know better how to respond. And it's also going to have them feel confidence in you. There's nothing worse than feeling like you don't know what the conversation is about or what's happening. So listen. Those are my big points. Let me unshare my screen here so you guys can see me again. And what questions do you guys have? Anything about communication? And I'm going to get the link for you guys to the lesson. I know some of this seems like such basic knowledge and you're like, I got it. And then you get in there and it's hard. Totally different. I've had lots of, believe me, I've had doctors yell at me, snap at me. But you get used to communicating with them, and then having a good way to respond back to them is always helpful too, to just kind of calm it down a little bit. That link that I put in should take you right into, if you click it, the Confidence in Communication course or lesson on NRS&G, and then you'll see the rest of the communication pieces in there. There's SBAR information and how to use that. Do we need a certificate to translate? Oh, you're bilingual. Your nurses are going to love you. Yes. So, okay. So in real world versus NCLEX world. Okay. So you typically, and I will say this is at my hospital, so it could be different other places, but they have to go through, a translator has to go through specific training to be certified. I don't know if that's the right term, but to show that they know the medical knowledge, because some people are bilingual-ish but don't know all the medical terminology. So I would say that yes, you need that to translate, but you should get it, because you get paid awesome if you can translate. You're super helpful and resourceful to other nurses on the floor. Other nurses will probably still take you in and use you for small words and things like that, which is probably fine, but big translations of like consent forms and all that legality stuff, you really need to be covered by the hospital. So that just means that if you have a certificate or you're certified or whatever the terminology is to translate, then the hospital is going to help cover you, like liability wise, if that makes sense. Hello, Marissa. But that's awesome that you're bilingual. We have a few of our nurses that are, and it is so helpful. Through the workplace if hired, or is there a website to do that? I'm not 100% sure. Our nurses got certified, but I think it was through a program that the hospital had. That might be something just to ask at the hospital, or just to even Google and see if there's something, or call. If you talk to the human resources at the hospital, then they would be able to tell you too. That would be another good way. Yes, dig more into it, because you want to be covered liability wise, but it's just awesome to have. And if it's obviously bilingual comes natural to you, then go for it. That'll really help make sure you put that on job applications too. Marissa, I think everybody else can hear me because they're answering the questions. Maybe try to refresh, or make sure if you're on your phone that you don't have the little silent button hit. Sorry, you can't hear me. As I'm telling you what to do, realizing that you can't hear me. Thank you, Pang. Sorry. I love that I just gave her a whole detail what to do and she couldn't hear me. And nobody else caught that to stop me. Hopefully she gets it straight. All right, what other communication questions do you guys have? So for NCLEX and testing world, try to make sure you know about the translator thing. So no family members, you know, or friends that can translate. Make sure you're always using a service. So whatever the hospital has. Kathy, I really need to remember to concentrate on listening because I'm always trying to think of the next thing to say. Yes. You're welcome. I hope that helps. Yeah, it's really important because, and I think people can tell that too. I know I had a friend in college, and her family were very good at talking with conversation, but I always felt like they were not listening to what I was saying. One, because I felt like I was always retelling them the same things every time I saw them, but also I could just tell that they were kind of thinking of the next thing to say. Like they were ready to respond quickly to the next thing versus listening to what I was saying. How fluent do you need to be in medical terminology? If you're talking about to be certified, like we were talking about before, you need to be fluent in it. If you're talking about day-to-day get by, you don't. You just use a translator service. But are you bilingual also? Okay. Yeah, they are completely fluent. We have our translators come in. Occasionally they'll have us repeat something, like maybe we talk too fast or whatever it is, or they're trying to think of the word, but they are fluent. Then otherwise you just get on that helpful translator line, which is super helpful. What other questions do you guys have? I wish I was bilingual. Oh, good, Kathy. I'm glad it was great. I feel like some of it is very just common basic, call them, because usually we say like a rule of thumb is 20 minutes for them to call back. So here, let me tell Marissa, instead of talking. So sorry, guys. Hold on a second. Okay. So documentation. Okay, so you want to document when you call them. And then within like 20 minutes, if they don't call back, you would say, Paige, Dr. So-and-so again. You never want to be like, the doctor didn't call me back, but you're just showing what you are doing. So making sure that includes that you're covered, so that the next day, if someone's like, gosh, or later that night, they realize like, you know, something's gone on, a doctor hasn't called back, it shows that you have done it. So that kind of communication, if you're having specific things with a patient, that would be, okay, for instance, the area I work, sometimes Child Protective Services is involved. And so we're trying to document things like communication that the parent has had with us, like the parent called to check on the child, or at the end of the day, no communication from the parent. Because hopefully you would think that that would matter, right? If they've called to check on their child or not. So it's communicated so that way in a court, they could pull it and see what has happened. So those are important things to kind of document. But make sure you're definitely at least documenting when you call a doctor. That's really important. And then when they call back, what orders you received, no further orders, or that kind of thing. Okay, I was just making sure I didn't miss any questions. That was all about poor Marissa. Other communication things. That's so strange that there's a mute button that drops down. I haven't seen that. Some more with NCLEX. Okay. I'm trying to think what else. Okay, so our translator, the documentation thing would be key on there. So things like if the doctor, that you would document the time that you called. If the doctor did not call back, then you would put in there. You don't want to say, you never want to make it like you're pointing fingers at somebody else, even though that can be really frustrating. So like, let's say at 10 a.m. I call a doctor, I put 10 a.m., call Dr. whatever. And then at maybe 10:20, 10:30, put 10:30, page doctor again. So it's not like never heard from doctor or waiting on doctor to call. Like you're just saying exactly what you're doing. Is what's important, because in a legal issue, you don't want to be pointing any fingers. So that is important. I'm trying to think what other communication things for NCLEX. Those are so basic questions. I'm hoping you wouldn't have those. I want you to get the harder questions. It means you're doing better. Communication with patients. So that is probably more so on NCLEX. So that's things like we want to do the open-ended questions, right? So leave it open for them to respond, not shutting them off to just yes or no. Having that therapeutic communication, so therapeutic touch while you're communicating with them. I feel like the communication questions are all really difficult. I don't know about you guys, but I'm like, well, I wouldn't really ever say that, but I think that that's probably the right thing to say. So sometimes when I was in nursing school and I'd look at those communication questions, I would read it like to think, which one would I want the response to? What would feel the best response? But those can all be really difficult. Okay, for NCLEX, you are not supposed to ask why questions. So you don't want to say like, why did you do that? Or that kind of thing. You want to spin it a little differently. So you can still kind of ask the same question, but not put why, if that makes sense. Yes, right. It can make them be defensive. So you don't want to ask why, or like, what did you do to make him hurt you? I feel like that's always a question on a test when it's not their fault or whatever. Sample NCLEX questions you have on your website pretty similar to what is on easier or hard. So we have our MPQ a huge range of questions. So we have where they're kind of easy, and then we have where they're more higher, I shouldn't say easy, but not as higher level analytical questions, more of just comprehension, like you know this because of this, where you get into the analysis questions and it's more kind of piecing things together. So when you're doing your NCLEX, it should be that if you get this question right, then you get harder, and you keep getting up and you get scored based on that. So the NCLEX is a computer system where it will pull questions. So if you get a higher level question and a more analytical question, then you're going to keep on that track of analytical questions. If you get it wrong, then you might drop down to just a little bit more of a comprehension base. So it's set up like that, and there's a ton of questions. Yes. Communication side, because normally I wouldn't say the things they say we should to a patient, which is right. I know, I agree. It is, I think communication questions are really difficult, and they are for sure one of the ones or questions that I always think 2 or 3 are right, and I'm really just guessing. I'll be honest, I'm right there with you. So just remember your basics, like don't ask why. If the answer starts with why, that's not the answer. If it's a yes or no question, not the answer. And then hopefully you've narrowed down to only one, maybe 2, and then can make the best choice. I always felt like they were very like, it seemed like it was a nurse that only had one patient, which is never how it's going to be. But yes, the communication questions are very difficult, but just know those basic things, and then hopefully you can narrow it down enough. What other questions do you guys have? Should we be worried when we're using the NCLEX, seeing questions from MPQ Bank and passing the NCLEX? Hold on, I gotta reread this. Should we be worried when using the NCLEX, seeing questions from MPQ Bank and passing the NCLEX? Oh, like, because you're getting the same question again from an MPQ. I would think if it was just a few questions here or there, it would not make that big of a difference. Yes, I know, I understand what you're saying. I don't think it would make that huge of a difference because it's just a couple questions. I'll tell you that I know that they're really working on it to make sure that people aren't getting more than one or the same question more than once during the NCLEX. I think you will see MPQ questions repeated, like the ones from each lesson in the NCLEX, because they're all pulled from that in other places. But if you want a more concrete answer, because mine was not 100%, if you send Tammy at contact@nrsng.com with just the attention to the NCLEX, she will quickly respond to you, I'm sure, and let you know that. But I don't think that getting a repeat of 1 or 2 questions is going to make that huge of a difference. Good. I'm so glad it was one of the best practice tests you've used. I always say I wish this was around when I was in school, for sure. I was just going into those like Saunders books and just practice books and doing questions over and over again. But yeah, I'm glad it was helpful. It's okay, you can use it now. And just keep practicing. Yes, good. And you should, there's those study plans, have you seen, for if you've signed up to take your boards again, there's study plans that can help show you what to do each day to get you prepared. Have you seen that? Okay, good. I was going to say, Tammy's good at, she'll set you up with one of those too, for anybody else that needs it. And I think actually Tammy has her maybe first or second tutoring session coming up that is about doing these. If you look on the tutoring. So Peng, so it's on tutoring, and I think it's this week or next I saw, and it's about making a study plan, and she shows you how to do it, or is going to. And then if you do contact@nrsng.com and put it to her attention with study plans, she will help create one for you. She'll make a video for you to get you the most out of the site. Either her or Sandy will. Yes, do those study plans for sure. Because it kind of shows you each day what to do. It can be really overwhelming. So this just shows you, okay, I need to do this day, and then you can just check that box off that you've done it. Oh, good. Melissa said she's great at setting it up. So she's clearly done one, so great. So take advantage of that. There's so much on the website, and we are all here to help you and want you guys to be successful. So anything we can do to help you, we're happy to do. So join her tutoring session, and then, yeah, just contact them. They'll get it. Oh, good. Yes, there is one. I forgot that there was one for repeat test takers. Good. Yeah, take advantage of whatever you can. I love the all tutoring sessions. They're awesome. I kind of want to jump in some of them just to sit back and listen and be reminded about different things that I've sort of forgotten. Good. I'm so glad. I'll have to pass this on. Our team will be happy to hear all the great reviews you guys are giving. All right, guys. Well, if you don't have any other questions, I hope this was helpful, and will give you a little bit more confidence next time you communicate. Remember that as you're working on the floors, listen to those nurses have the conversations. Yes, take it. Well, at least you're taking advantage of it, Melissa. Some people will be sleeping in, but I'm glad you're here studying. Good. All right, guys. Well, happy nursing.
The 5 steps in the nursing process are assess, diagnose, plan, implement, and evaluate. We use the mnemonic ADPIE, A-D-P-I-E, to help us remember that. Now, the reason it's so essential you remember these steps in sequence, ADPIE, is that as a nurse, you should never do something until you've done the step before it. First you assess, then you diagnose, then you plan, then you implement, and then you evaluate. It's really simple. ADPIE, A-D-P-I-E. Assess, diagnose, plan, implement, evaluate. The next time you take an NCLEX exam, or the next time you take a test in nursing school, or the next time you see a patient on the floor, I want you to remember these steps. ADPIE. Assess, diagnose, plan, implement, evaluate. You're never going to forget it now. ADPIE. Let's talk really briefly about each step in the process. First is A, for assess. When we assess, what we're doing is we're gathering all the information we have available. We're looking at everything. We're taking vitals. We're using objective and subjective data to gather everything that we can to really see what's going on in the situation. Then let's talk about D, diagnose. Once we have all of our information from assessment, we can then diagnose. We can then say, okay, this is what's happening. This is what's going on. This is all the information I have, and this is what's happening with this situation, with this patient, with this question. Then P for plan. Once we have all of our information gathered and assessed, once we've made a diagnosis in D, now we're going to plan. That's the P in ADPIE. So with all of this information, we're then making our plan. What are we going to do next? Now that we know what's happening, now that we know we have all the information, what are we going to do about it? That's the plan part. We make the nursing care plan, we plan how we're going to answer the question, or we plan what we're going to do next. Then we move on to I. I is for implement. We've made our plan, that's great, but without implementation, it's basically worthless. With I, ADPIE, the I in ADPIE, we're implementing our plan. We have our plan, we've written it down, we know what we're going to do, now we actually do it. That's implementation, that's implementing the plan that we've created. Now the E, ADPIE, A-D-P-I-E, the E stands for evaluate. Having a plan, implementing that plan, assessing, getting all of our information, making a diagnosis, all of that's good, But did our plan work, or do we need to adjust it? So the E stands for evaluate. We've implemented our plan, now we're seeing how our patient responded to that. We're seeing, was this the right answer? Did this work? Are we getting the outcome that we expected? So that's evaluate. The next time you take a nursing exam, I want you to work through this. You never jump to evaluate, you never jump to plan, you never jump to implement until you've gone through assess, diagnose, plan, implement, evaluate. You always work in this order. What can happen to a lot of students is they want to diagnose or implement before they've either assessed or planned. So for example, you might get a question about a patient shows up shaky. Okay, so what should you do? The first thing you need to do is assess. One thing you can do to assess that is get a blood sugar. Don't just jump automatically to thinking that this is a patient having a seizure or that this is a patient with low blood sugar. Get that blood sugar first. That's part of your assessment. Once you have that blood sugar, you get it back, it's 32. Now you have a diagnosis. Okay, this is hypoglycemia. The patient is shaking, they have hypoglycemia. Now what's our plan? Our plan is to give them a little bit of glucose. We give them that glucose. Now we see what happened. Okay, we evaluate. Okay, the shaking's gone away after 15 minutes. We're good. That's the way it works. Never jump to your diagnosis or your implementation until you've either assessed or planned. And that's where I think I see most students make mistakes, is they automatically jump to a diagnosis when they have one piece of information. Now guys, over at nrsng.com, we have an entire huge database on nursing mnemonics. I want you to head over there, use that database. It's completely free. We have images, we have audio, we have everything you need to keep this straight. We also have a cheat sheet on nursing mnemonics. I want to make sure you guys get that. It's a free PDF download that you can use to keep some of these things straight, to keep some of these mnemonics in your mind, to help you memorize and retain the information that you've learned. All right, guys, I want you to go out and be your best self today. Happy nursing.
Show of hands, how many people have heard of the SOC method? Sweet. And the reason I ask is because by the time you're all done, you will all know what the SOC method is and how it works. So my first question is, how many of you struggle with pharmacology? Oh, there it is. All right, cool. So I know we just went to lunch, and I know that if I ask you to do this, somebody may go to sleep. But just for a second, I want you to close your eyes and imagine something. So imagine that you have $40 billion. I'm not giving you $40 billion, so don't ask. Tony might. Just kidding. All right, so now I want you to open your eyes and I want you to look. So this right here, this is a house in the area, in the Dallas area. It is a 14,000 square foot house. It's got 8 rooms, it's got 9 bathrooms, it's a 10-car garage, it sits on like 5 acres. So if you had $40 billion and you walked in to the realtor, let's say you walk into this house and you say, hey, I want to buy this house. And the realtor says, do you want to finance it or do you want to pay cash? You say, sure, cash. It's like, if you have $40 billion, this house is worth $10.2 million. It's like handing them a $10 bill. So in the grand scheme of things. So this is a Lamborghini worth about $450,000. You walk into the Lamborghini dealership, you've got your $40 billion. You're like, hey, I want to buy that car. And the dealer goes, cool, cash or finance? You're like, cash, cool. It's like 45 cents. I couldn't find a picture of the new Mac that just came out. It's worth about 10 grand. If you had $40 billion, be like a penny, right? So the reason I give you this idea of $40 billion is because $40 billion is actually the amount of money that people spend in the United States to care for patients that have an injury related to a medication error. It's a lot of money. So kind of give you an idea, Bill Gates is worth about $56 billion. So $40 billion, 6,800 prescription medications are available on the market. 7,000 to 9,000 people die per year as a result of medication error in the United States. If we walked into the emergency department and said, hey, what are the top 10 medication errors? Here is the list of those medications. With these red ones, who can, just a show of hands, who can maybe tell me what the significance of the red ones are? Deadly. So if you have a medication, what that means is if you have a medication error and you're working in the ED, you have a 50-50 chance of giving your patient a deadly medication. So why do we think this is? There's a problem. Over the course of your career, you're going to pass out like 172,000 medications. A lot of pills, right? So I want you to look to the person to the right of you and to the left of you. Two of you will say that pharmacology is the hardest subject. Agree? Cool. So if you know me, you know how big of a fan I am of Spider-Man. And there's a phrase that Uncle Ben says, with great power comes great responsibility. The reason I bring this up is because about 70% of the medication errors are actually caught by registered nurses. So you have this fantastic power to catch these medication errors. This number actually comes from during the process of getting a medication from the provider to the patient. There's different phases. In the ordering phase or the writing phase, when the physician or the provider says, I'm going to give this patient metoprolol, they're going to write it wrong half the time. And of that, 70% are caught. So this means that you have this huge, huge responsibility, and you have this great power to actually make your patient safer. So what is this? If this is the problem, then what is the solution? Socks. Cool. Actually, it's the sock method. So this is a method that we came up with. John actually came up with it. It's a mnemonic for learning pharmacology. It improves patient care by doing these three things. It improves patient safety, it improves patient outcomes, and most importantly, it helps you to hone the critical thinking process. As you go through your nursing career, you're going to learn that nursing is not just checking off boxes. There's going to be a critical thinking process, and by utilizing this method, it simplifies the idea of pharmacology so that you guys can get better understanding of it. So let's go through these. S stands for side effects. You all have this cheat sheet in a small, tiny form. And I want you to take this with you. So S stands for side effects. O stands for organ systems. C actually stands for class considerations and cards. And K stands for know or must know. And we'll get to all these. So let's start with S. So S, when we're talking about side effects of medications. When you look at a medication, you don't need to know everything about the medication. The first thing we're going to start with is the side effects. So if I look at the side effects, if I'm going to give my patient a medication, I need to know what are the life-threatening side effects that I need to know. That's the first thing I need to know. So if I give a medication and it's potentially going to drop their blood pressure, I need to know that, right? The next thing I need to know about are the organs or the organ systems that are affected. So if I give, for instance, if I give a narcotic, who can tell me, just blurt it out, side effects of the narcotic? Perfect. Respiratory depression, where at? Central nervous system. So now we have, what system is that? Neuro. And then in turn it affects what? Respiratory. And if we don't have enough O2, what happens? We die. We have perfusion. We have perfusion issues, right? So now we've hit the top three are our critical organ systems because we know that that one drug affects all of those in a way. Now there's this other idea of the opposite of the intended effect, which is called a paradoxical effect. So sometimes some drugs like antipsychotics, for maybe your patient is having a psychotic episode and you want to bring them down, you give them some Haldol, well, sometimes it can have the opposite of the intended effect and actually makes them more agitated. So if I know that if I give my patient Haldol that they could potentially become more agitated as a result because it's an opposite of the intended effect, I need to know that. Also want to focus on the key side effects. If I give Tylenol, do I need to know all 500 side effects of it? No. I need to know the big ones, right? And like we talked about with the narcotic, we need to focus on these ABCs, airway, breathing, and circulation. So we know that with that narcotic, we knocked out their breathing drive, and now we know that we have a circulation issue. So even though I don't hit all three ABCs here with the narcotic, I know that I hit those top three. Okay? Next one, organs and organ systems. Good segue. So medication systems can affect one or more organ systems. So we talked about narcotics, right? So we said that narcotics can work on the neuro, it can also work on the respiratory, and then it works on the circulatory center, or the circulation. Who can tell me what is another thing that we need to consider when we're dealing with narcotics that's not life-threatening, but it does affect another organ system? There it is, constipation. Patients need to be on a bowel regimen, right? So we need to know the target system. So we need to know the target system. We need to know that they also, so we know that with the target system, we're talking about the respiratory centers. We know that we want to focus on pain because it's going to work on those cell receptors, but we know that those side effects are going to also affect those organs. We also need to know that it's going to work possibly to make our patient constipated. Now, do I care if the patient's constipated or do I care if they're not breathing? Right. So we need to prioritize when we're talking about organs and organ systems. Okay? Next one. Class considerations and cards. This one's actually broken into 3. So this is the C of the SOC method. So class considerations and cards. So let's start with class. Class is actually broken up into 2 classes. You've got the pharmacologic class and you've got the therapeutic class. If we're looking at a drug, we want to know what the pharmacologic class does because it actually complements the anatomy and physiology. So what is it actually doing in the body? And when we look at the therapeutic classes, how does it help? So who can tell me what Prilosec does? I'm sorry, what? Prilosec, proton pump inhibitor. Yep. So Prilosec is a proton pump inhibitor. That is its pharmacologic class. Therapeutic class, how does it help? Anti-ulcer. Yeah, so with that one, we need to know why, like what it's doing in the body, and then how it helps. So famotidine or Zantac, those are 2 different drugs. One's brand name, one's generic. Those are H2 blockers, H2 agonists. Those are going to be a little bit different. Similar, so like with Prilosec, if we give Prilosec, we know that it is an anti-ulcer. Famotidine is also an anti-ulcer, but they are different pharmacologic classes. So this is where it gets into when we're talking about pharmacologic classes. So famotidine, ranitidine. In the speech that Sandy just gave, you guys got the pharmacology handout. If you look on it, you'll see that there are some, I'm going to look at yours real quick, steal it. If you look at it, it's a prefix suffix. So with those types of drugs, when we're talking about classes, that will actually help you to understand generic names. Lasanzapro, omeprazole, those are proton pump inhibitors. Famotidine, ranitidine, those are H2 blockers. They both do the similar things. Now, let's move on to considerations. When I give a drug, I need to know how to administer it, right? If I get an order for metoprolol, what's a metoprolol? Okay. What do I need to know about metoprolol? Give it what? As far as administer it. If I'm going to give it, should I give it fast or should I give it slow? Slow. Okay. If my patient's in SVT and I have to give adenosine, should I give it fast or should I give it slow? Fast. You slam adenosine. I need to know, so when I'm looking at a drug and I'm trying to understand it, what do I need to know about administering it? Okay? Flomax. Who has given a Flomax to a patient? Nobody's given Flomax? Okay. Flomax is a drug that works on, for patients with benign prostatic hyperplasia. And if you ever open it, it's full of granules, and they're very large granules. Who here has worked with a Dobhoff tube? Dobhoff tube. It's a nasoduodenal tube. So it's smaller than a nasogastric tube. It goes down the nose, into the stomach, and the duodenum. The bores, or the little holes, the fenestrated openings, are very small. You cannot give Flomax in a Dobhoff. It will clog the tube, you have to pull it out, and then you have to drop another one. And it is a pain in the ass. Hate doing it. But nonetheless, these are the things you got to be thinking about when I'm giving my drugs. So if I get an order for Flomax, they're like, hey, it's supposed to go down the Dobhoff. You have to say, excuse me, I can't do this because I'm going to clog the tube. So you have to figure out different things, right? So patient education. What should I think about when I'm educating my patients on, let's say, Lovenox? Who here is given Lovenox? Everybody's given Lovenox, right? Yeah, a lot of Lovenox. Some patients go home on it. We got to show them where to give it. What's the one thing that we need to know about Lovenox when we're giving it every day? Anybody? Alternate sites, right? So that's something I tell my patient if they're going home on the low molecular weight heparin, so that's the Lovenox. I need to make sure that I tell them that you need to alternate sites, because if not. So that's the other thing. Now, this one is really important. So what is vitally important about a medication when I'm learning it? So we talked about the metoprolol. Let's say they're getting metoprolol and maybe they're on some sort of other blood pressure medicine, and the provider says, hey, you need to give this metop. You say, sure. You look at it, you're like, you know what, that's a really high dose. Hey, we want to give 10 IV, which is kind of high. We're going to give 10 IV. I know that if I give that, I need to make a decision about it. So can I share a brief story with you? When I worked in trauma, I had a patient, self-inflicted gunshot wound, and his heart rate was really high, his blood pressure was really high. So I get an order for labetalol of 20 milligrams. It's a pretty moderate dose, not unheard of. Was a little bit hesitant, and they said, give it. I was like, it's kind of high, can we maybe start lower? No, give it. I'm like, all right. So I gave 5. Labetalol, because it's a beta blocker, you give it slow. As I'm giving it, I'm noticing heart rate come down. Okay, cool. I get to 5. He was at like 110, and he dropped to 90. That's after 5, and I have an order for 20. I'm like, I'm going to go ahead and give the other 5 and see what happens. I hit that second 5, and he dropped to 60. So I had an order for 20. What do you think I did? I called that provider. I said, hey, come here. Come here. You see that number? He goes, yeah. I was like, that's after 10. Like, will you please change the order because I'm not giving a 20. So the important thing that you need to know about this is be a clinician. Don't just, nursing is not checkboxes. When you get a MAR, you don't just give drugs. You don't just give insulin arbitrarily. You don't give metoprolol. You don't do these things just to complete tasks. It is your job to be scientist, to be detective, to be nurse. You have to do all of these things, and part of that is being a clinician. You guys are working really hard, and I don't want you to make a mistake that will result in a medication error because you just did something, right? So that's what I mean when I say vital information. Cards. So inside the academy, we have these, and we'll make sure somehow we get these to you. I think it's actually on a blog post. These are cards. This is, what I want you to do is I want you to go get a binder. I want you to print out as many of these drug cards as possible. And you are going to practice the drugs you know. Okay? You're going to start with the generic name. We already talked about that. Trade name. So the brand name is another. Pharmacologic class is what it does, and therapeutic class is how it helps. If we want to talk about pharmacodynamics, pharmacokinetics, we're talking about action, why we give that, we're going to fill this whole thing out. You're going to organize them, and then once you think you have them memorized, you're going to throw them away. Did I hear what? Yeah, exactly. That doesn't make any sense. Guess what? You're going to print more out, and then you're going to rewrite them from memory. We're going to do this. We're going to organize them and study them and rewrite them, and then we're going to start over. And we're going to do this until we know the drugs. Which leads me to my next one, which is know or must know. There are lots of medications, 6,800 medications on the market. Medications are based on needs and research. So if there's a new need, I know that there's probably 5 or 6 on the market H2 agonists. Does the market really need more H2 blockers? Probably not. They're relatively expensive. We've seen that over the course of decades that famotidine and ranitidine do really well for patients. We know about the likelihood of these small side effects, but we don't need to go out and put out a new one, right? So some of these are based on needs and research. The low cost and the low risk ones are the ones going to be used most common. So if you are on a unit and you have a drug like Zantac, Colace, these things are low risk, and you're going to want to familiarize yourself with those drugs. So if you're in an LTAC or a SNF, everybody know what LTAC and SNF are? Okay, long-term acute care facility or a skilled nursing facility, do you need to know about giving an epinephrine drip? No, because it's not applicable to you. It's not that you wouldn't ever give epinephrine, but in that case, it's one that you don't necessarily need to know. If I'm working in OB, do I need to know about oncology drugs? Probably not. So these rare drugs are going to be used in rare cases for small amounts of those cases. Now, Sandy talked about this 80-20 rule, Pareto's principle. And where it applies in pharmacology is that 80% of the drugs are given 20% of the time. And if we flip it, 20% of the drugs are going to be given 80% of the time. So John wrote that book, The 140 Must-Know Meds. I've looked through it, and I've given about 80% of those. So that's where that comes from. So when we talk about know, we need to talk about what we need to know for the unit we're on. And then we also need to know, I don't need to know everything about the drug. I need to know its side effects. And I need to know what organs it affects. And I need to know what class it's in. And I need to know what I need to consider. So we talked about drugs on a unit, right? So if you're in that skilled nursing facility, you don't need to know about the vasodrip. You don't need to know about what they were titrated on a cardine drip. The other reason you need to know this is because your patients rely on the medications that are frequently given on the unit or in your area that you're practicing in, and that you need to know them intimately. They rely on you for their safety. They're trusting you. So when you get done, and the 67% of students who struggle in this area, we want to make sure that when you go out onto that floor, that when you walk onto that med-surg unit or that OB floor or that ICU, that you are well aware of any of the drugs that you give, because our patients rely on them so much. So when I'm looking at a drug, I know that I need to know side effects, organs, class considerations. I need to practice them with the cards, and then there's things that I need to know. But I'm not necessarily going to look at every drug. This is how I remember them, but this is how I actually consider giving them. When I get report, and I'm going maybe from, let's say I'm giving a report, and I'm giving a report from maybe an ICU to the floor, will that nurse that I'm giving report to, will they care that that patient was on epinephrine on an epi drip a week ago? Patient's totally stable now? Probably not. We want to flip it. If you're receiving a report and you're on the floor and you're getting an ICU report, and that nurse giving you a report tells you, hey, he was on an epi drip 3 weeks ago. He's stable now. He's about to go home. Probably not important. So when I'm looking at drugs and medications, I need to first look at the organs that are affected. That's the first thing I want to look at. I need to know the target system. I need to know what other systems could be affected. And then, do I need to know this? Do I need to know this for my patient? Do I need to know that they were given some sort of chemotherapy drug once? Probably not. Which means, if I don't, I can scratch the last two off. He was given some sort of chemotherapeutic drug. I need to maybe take it into account, but it's not going to affect the way I'm caring for my patient. But if it's one that I do need to be aware of, okay, cool. I need to know what organs affects. I need to know, what things I need to consider when I'm talking about, do I need to know this med? And then class considerations and cards. All right, cool, I'm on a unit. I need to know these 15 meds because I'm going to get them daily. And then I need to talk about the side effects. So I'm going to work on those life-threatening side effects. I want to look at my ABCs. And I want to look at those 140 must-know meds. I don't need to know all 500. Like I said, no, I don't need to know all 500 of the side effects of Tylenol. I just need to know maybe the first 5, the ones I'm going to see most common, right? So, like we always say, we hope that you guys are having a great time today. We hope that you've learned something. My goal here was that you walked out of here knowing what the SOC method is. We want you to take this and apply it to the way that you learn drugs. There are so many medications. I feel like I got a little bit of a pass because I was actually a vet tech before I was a nurse. I spent about 10 years in the veterinary industry, and there are lots of drugs that you give, and I think about 80% of the drugs that you give in the 80-20 rule, right? About 80% are human drugs that we give to our animal friends. And I got a little bit of a learning, I got a jump start. But when we're dealing with these drugs, we want to make sure that you have a way to learn them, to become intimately aware of them, to know the ones that make sense. And that you don't need to know all of the drugs. It just doesn't make sense. So go out and be your best selves today. And as always, happy nursing.
What's up? Welcome. Who's here from the last session? Who just attended the last session with Sandy and is back again for more? Who can't get enough? Steve, of course, Steve. Just had to make sure you were in here, man. Cool. Today, we're going to have Tammy, who maybe some of you guys have seen on social media, especially like in the Facebook group, or possibly on Instagram. You've messaged her. Can't get rid of me. So maybe some of you guys have seen Tammy before. Maybe you've talked to her before. But Tammy, before starting with NRSNG, she was actually a surgical tech at one of the largest and best orthopedic surgery hospitals in the country. So I know there's a lot of M is back. So I know there's a lot of you, or me specifically, as I was going through nursing school, I had a lot of interest in OR nursing. What does it mean to work in the OR? What would it look like? What would it feel like? So that's the whole term red line. You guys know as you walk through the hospital, there's that big red line that's where you got to be clean. That's where you got to be sterile. That's where you do the surgeries. So have you guys ever considered OR? Have you had a chance to be in the OR yet? Have you had a chance to look around the OR yet? Steve, yeah, cool. One of my first experiences was actually the OR with a podiatrist, and I never have felt queasy or anything like that. It's never something that I kind of have felt. But when he started like drilling through an ankle, for some reason that to me kind of set me off. But cool. So today we have Tammy with NRSNG. Her career, she'll tell you a little bit about what she's done in her career, but she's got a lot of experience in OR. So she's had a chance to work with a lot of nurses in the OR and see kind of what makes a nurse successful in the OR. So if you have any interest in it, if you're considering going OR, if you just want to know more what it's like, Tammy's going to help you guys with that. So be sure to ask her all your questions. Be sure to get everything answered you guys have today about OR nursing.
All right. So you may be wondering, what can a surgical technologist teach me about how to be a successful OR nurse? I was doing the math as I was preparing for this session, and I calculated I've probably scrubbed about 8,000 cases from a tonsillectomy.
Aesthetics.
From a tonsillectomy to a heart transplant. I've been called in at like 2 a.m. in the morning for a 9-hour bilateral femur fracture. I've seen what makes a successful nurse, and today I'm going to show you guys that. Can you guys see my slides here? So that's kind of what it looks like in the surgery room. As John stated, I landed my first job out of surgical tech school at Dallas Children's Hospital. So it was pretty cool, loved it. So today I'm going to teach you, I want you to understand the different stages of surgery. I'm going to tell you what makes a good operating room nurse, and I'm going to teach you guys how to stay calm in stressful situations. So let's go ahead and dive in first to the different stages of surgery. So there's 3 different stages of surgeries. You're going to have pre-op, you're going to have intra-op, and you're going to have post-op. All 3 of those make up what we call the intraoperative or perioperative services. All right. So let's go ahead and, sorry, they are messing around with all this stuff. Okay, so let's go ahead and dive into the first part, which is the pre-op. So before you go and get your patient, you want to make sure your room is all set up. You want to make sure that you're gather all the supplies that you'll need for surgery. So each surgery is going to be different. So for a tonsillectomy, there's like a ring right around her head. For a tonsillectomy, you're going to have different instruments than you would for, say, a femur fracture. So you want to make sure that you have all of those different supplies that you'll need. You want to make sure that your scrub tech and your anesthesia provider has what they need. So for instance, you want to make sure that you have the right medications that your anesthesia provider will need for that specific case. If your scrub tech is ready, then you can go ahead and initiate the first count and also provide medication to the surgical field that will be needed for that procedure. So once you've done all of that, then you will go over to the pre-op area and you'll pick up your patient. From that time, all of your attention needs to be on that patient. You're going to take them back to the OR, and go over to the bed and help with the intubation process. Now, guys, imagine this. This really happened to me. So my nurse and my anesthesia provider, they come back with our little tiny 7-pound baby from the NICU. The anesthesia provider carries him over to the OR bed and begins to mask the baby down. So it seemed to be going well. So the nurse went over to the other room to pick up a blanket for the patient because the patient was really cold. As she left the room, this anesthesiologist begins to lose the airway on this patient. He needed to reach behind him inside of the anesthesia cart to grab oral airway, which is what you'll see here. So he tries to turn around to grab the oral airway behind him. And every time he moves the mask, the patient begins to turn blue because the airway, he can't get a good seal in the airway. So what do you do in that situation? The nurse is in the other room grabbing a baby blanket for that patient. Is keeping the baby warm important? Absolutely. But guys, what are the ABCs? Can anybody jump on here and say that? Give it a second. So airway, breathing, and circulation. So C does not stand for cold. There you go. So C does not stand for cold. So stay with your patient, guys. Once the patient is intubated and the tube is secured, then go into the other room and get the patient blanket. So let's go ahead and jump into the intraoperative. So once the tube is secured, the surgeon will come in. He'll position the baby or patient however he wants for that particular procedure. He'll go out, he'll scrub his hands, come back in, and then the surgical tech will go ahead and gown him and glove him, and then drape out the patient. Then the surgery will begin. So during the whole surgical procedure, your job as the nurse will be to chart, open supplies that might not have been open before the case began. And as well as you always want to make sure that you stay aware of what is going on during the surgery. So pay attention to that surgical field. So for instance, I was doing a dialysis catheter removal on like a 2-year-old patient, and the catheter was being real stubborn. So the surgeon was trying to get that out and he tugged. As soon as he did that little tug, I look up, and right here, this is usually how the patients are draped out so that the anesthesia provider can keep an eye on the airway. I look up and I see my CRNA pull the drape down and say, "What the hell did you just do?" So apparently the surgeon pulled a little too hard on that catheter and the baby was bleeding internally, or something had gone on to make the stats begin to drop. Because the CRNA was paying attention to the surgical field and what was happening, I was able to apply dressings to the wound. I was able to secure my back table, and then we were able to begin the CPR on that patient. So make sure you're always paying attention to what is going on, and you're not on your computer looking around at your next vacation or whatever. So after the surgery and when the surgeon begins to close, you want to make sure that you count with your surgical tech. So counting can be real monotonous because you're going to be doing it quite a bit during the procedure. And as you begin to close, you're going to do initial count as he starts to close real deep. So I'm going to tell one more story for you guys. I was doing, I can't remember what the case was, but it was a lobectomy or something on our patient, and I did my first count with my nurse and we were off. Our count was off. That's kind of common sometimes during these long procedures. A count can be wrong because a sponge can be hiding underneath the drape or in the trash. It actually got thrown away. So I let the surgeon know. I was like, "Hey, we're missing a sponge." And he's like, "Okay," and he continues to close the patient. The nurse went and looked inside the trash, and I was looking under the drapes trying to find that other sponge. And we count again, and the count was still off. We notified the surgeon again. We're like, "Hey, our count is still off." And he says to us, "There is no way that sponge is in this wound." So he proceeds to apply the dressing to the wound. He breaks scrub and he leaves the OR. The anesthesia provider goes ahead and reverses the anesthetic and begins to wake the patient up. But at our hospital, our protocol is if we're missing a sponge or the count is off, you have to do an x-ray. So we call the x-ray tech down, and she comes and takes a picture of the surgical site. And sure enough, the sponge is left right under the left lung. Yikes. So if we had listened to that surgeon and we were like, okay, the surgeon knows best, he has eyes on the field, he knows what was inside that patient, what came out, that patient would have gone upstairs and he would have been the only kid in kindergarten at recess with a sponge inside of him. I'm only kidding, I'm making light of this, but I just want you guys to understand how important it is to count. So make sure you do that and you trust the policies and make sure you follow those policies. So let's go ahead now and dive into post-op. So once the surgeon has broke scrub, he's draped or he's applied dressings and everything, he's going to leave, and now you're going to go back up to that patient and the anesthesia provider and help with extubation. During this time, you're also going to call PACU, ICU, back to the floor, wherever the anesthesia provider and the surgeon feel is best for your patient to go and recover. So you're going to call, you're going to give a report to that nurse who's going to be taking over for you. Then once the anesthesia provider is ready, you guys are going to go and take that patient to the designated area. So it just depends on where it is, like I said, and then you're going to give a report to that nurse again. Once you get there, make sure you tell them the procedure, any complications, the medications. Make sure you give a real detailed report on what was done in that case. So now those are the different stages of surgery. So pre-op, intra-op, post-op, and they all make up the perioperative services. I really went fast in that, so if y'all have questions, you can feel free to ask me after. So now I want to jump in and talk about what makes a successful OR nurse. So there's lots of different things that will make you successful as an OR nurse, but I pulled out the top 3 that I felt was really important and what helped me be able to work well with my nurses. So they're teamwork, willingness to listen, and patient-centered care. So I want to jump into each one of these. First one, step 1, teamwork. So you are a team, from the anesthesia provider to the surgeon, the scrub tech, the x-ray tech, which is right here with me in this picture. You guys are all there for one common goal, and that is your patient. So think about it. If anybody was missing from that team, that case would not be as successful. So keep that in mind as you're working in the OR. The next step is be willing to listen and take to all your team members. So what I mean by that is each one of your, be willing to listen to what other people have to say in the room. They might actually have a better way of doing things. For example, I worked with a nurse and he had the attitude that he knew everything. And it was real hard to work with him. If you asked him why he was doing something, he would just say, it's just the way that it is, and would not take your suggestions. So be willing to listen, because somebody might have a better way of doing things, even if you have been doing it this way for the past 20 years. So that is step 2. Step 3 is you are there for the patient. So as soon as you get your patient from pre-op and take them back to the OR, remember this, guys, be the voice when they do not have one. Your patient is literally taking their lives in your hand, right? So be their voice. All right, now I want to talk about the last thing, and that is how to stay calm in stressful situations. So if you guys learn one thing from today, I want it to be this. And it doesn't just apply to working in the OR. You guys can use this anywhere you decide to work as a nurse. And that is, when things get tough or when you start to feel doubt, remember to stay calm in those stressful situations. So can I share one more story with you guys today? Awesome. So as I arrived to work on a Monday morning, I got a call overhead. I was in the locker room changing, and the charge nurse says to me, hey, hey, Tammy, hurry and change and then come meet me up here at the front desk. So I was like, okay, that's never real good on a Monday morning, anytime really. So I changed real quick. I head down to the front desk, and my charge nurse says, Tammy, you are the extra person today, and there is an emergent case up on the 11th floor in the NICU. I was like, okay, what is this case? And she said, it's a general case with Dr. So-and-so. So as John told you, I was an orthopedic tech, and this is a general case. And not only that, it is an emergent general case. So I was really, really scared, guys. I was shaking. I was like, okay. I was like, gathered all my supplies. So basically you're taking this OR room. You guys can't really see this, but you're taking an OR room right here, all of these instruments and sterile supplies and everything like that. And you're taking it up here and you're transforming a little NICU room into an operating room. So I gather all the supplies. I make my way up to the 11th floor and the elevator doors open. I don't know if you guys have ever been involved in a code or you've seen a code, but you know where they're happening because there is a shit ton of people. So I walk off the elevator, I make my way down to the NICU room where this code was happening, and I see the family over here with the chaplain and the social services. They're crying because their little tiny 2-week-old baby who was healthy a couple days ago is now coding up here in the NICU. I was so scared, y'all. I make my way in, I look, and I see about 20 people in there taking turns doing compressions on the baby and people writing things down. I see the surgeon coming up to us, and she says, we've just pulled out all of the lines on this baby, and we have no way to access. You guys need to open up STAT for a central line. Now, it was so, I can't stress it enough, guys. I was shaking, but I was like, okay, I open up, I gown the surgeon, I glove her, and we go and we drape out the patient. During the entire time, they're still doing compressions on this patient. I hand her the knife. She makes a little tiny incision in the neck for the central line catheter to go in. And she hands the knife back, and I brace myself. Because I don't know if you've worked with doctors and surgeons, but in stressful situations, they tend to be a little bit more hyper as well. I brace myself for the hemostat, right? But to my surprise, she turns, she looks at me calmly, and she says, hemostat, please. Chaos turned to calmness. And I was able to think more clearly. I was all like my shaking, everything went away because of the way that she acted. From that day on, I told myself, I want to be like this in every case, because the way you're able to think, the way you're able to concentrate is so much better when you're able to think clearly, when you're not stressed about what is going on. Now, you can't always choose your surgeons or your doctors. So I came up with 4 tools that have helped me to be able to get to this point. Now, I'll be honest, it is hard to do it, but it really does help. So I'm going to share those with you guys right now. So the first one is positive self-talk. So for example, if I had a case that I didn't know what it was or I was scared, I would always be like, I would stop completely what I was doing, and I would say, you can do this, Tammy. I mean, it helped, guys. It really did. So this may be real contradictory. The second step, it may be contradictory because you're always taught to anticipate the surgeon's needs, to be one step ahead. However, I found that I would anticipate the needs, but I would take the case minute by minute. By doing this, I was able to alleviate those fears and be able to stay calm in those situations. The third thing is I would ask. If I didn't know what the case was, or I was unaware of how this surgeon operates, or I didn't know what this instrument was, I would go and I would find a friend or the charge nurse or anybody, and I'd be like, hey guys, Can you help me out here? And they would always help out. You always find at least 1 or 2 people that are very helpful. Now, the fourth thing is, and it kind of goes along with asking, is I would prepare the night before. So the day before, I would look at the schedule and see where I was at. If I didn't know some of the cases, then I would go home, I would read textbooks, or I would ask a friend how this case went, or what instruments I would need for that case. So those are the 4 steps that I used to be able to stay calm and stay aware of everything that was going on. So whether you decide to work in the operating room or someone else as a nurse, I want you guys to remember that you can do this. You guys hear this all the time from all of us at NRSNG, but you can do this. Now, as you're preparing for your quizzes, your exams, or studying for the boards, just tell yourself, when you start to get stressed, say, I can do this. From all of us, like John said, I'm your community manager here at NRSNG. So I am on the Facebook group, or you guys can always email me directly, but I love hearing your successes. I love answering all your questions. So if you ever feel like you need to reach out, please do so. All of our support ladies here, they're awesome, and they will also help you out. So anybody have any questions? Thank you so much for listening today. If you don't have any questions, I actually have some surgical supplies that I can show you since we have about 5 more minutes. So I was talking about a central line, and this is kind of what a central line looks like right here. Kind of pull it out. This is a tiny one that you would use on a little tiny baby. So I'll kind of show you guys how this works. It's pretty cool. So there's different catheters that you put in. So this right here is the actual central line. So this part, they'll put the 18 gauge needle, or this one's a little smaller, but they'll put it in to kind of find the vessel or whatever. And then they'll put this sheath in there, and then they'll feed this down, try to get it in the right area that they want. And then they'll cut it. So they'll kind of measure out, cut it, and then this will kind of hang out, and this is where the medication will go. So that is a central line. You have the wire that feeds down into the... How common are nurse assist for surg techs? Honestly, like in the hospitals that I've worked at, you really just had like the surgical technologist, and then the nurses would just be the circulators. But they really like it when the nurses know how to scrub, and same here. Sorry, I'm new to this system. So they really like it when the nurses know how to scrub, because a lot of times you'll have to go and scrub a case, but usually they'll put them with like simpler cases, so unless you feel comfortable doing it. But as far as like nurse assist, we really didn't have just one nurse that was just to scrub cases. So yeah, so that's the central line. They'll use this catheter to kind of pull to make sure they have the needle in the right area to get some blood back. So that's the central line. Does anybody know what this is? This is a bovie. So this is used to it uses to cut and cautery. There you go, cautery, awesome, and cut. So yeah, they'll use this for that. So this right here, this is for tonsillectomy. It's called a suction bovie. So it suctions and it cuts at the same time. And the most common place to use it is, can't really see it. The most common place to use it is for tonsillectomy. So this right here is just a plunger. It cleans out, because during a tonsillectomy, there'll be a lot of gross stuff, chard and everything. So they'll use this to push out all of the stuff to keep it clean, so you can cut off really well. So let's see here. Then we just have this right here, I can't really see it, but anyways, Dermabond. In ICU, sometimes we use those on difficult intubation. The suction bovie you used on difficult intubation? I guess that makes sense. To guide. Oh yeah. For sure. So another one, here's a very common instrument. I talked about this in my case. This right here is a hemostat. So we use these a lot in surgery to dissect. So they'll just put it on and they'll just dissect down to wherever the surgery is. And then also they'll use it to kind of hold vessels or whatever. And then a lot of times actually they'll use this, they'll put it on the vessel or artery or whatever, and then they'll use the bovie to touch the end of it to cauterize it. So it's kind of cool. Anyways, do y'all have any other questions for me? I have some suture. Here's a proline. A proline suture is a lot of times used to tie off different arteries and stuff. Also, sometimes they use it to close deep. So a taper needle, so there's different types of needles as well. This taper one, this means that you can use it on like a vessel or something like that. Reverse cutting, you never want to use this. You want to make sure you have the right suture because you're going to have a ton of different monocryls, which is usually used for skin. But if it says cutting on it at all, you do not want to give it to the surgeon if he's trying to, like, say, for instance, suture a vessel back together or like a tendon or something. You don't want to give it to him because it will cut. But a taper needle is one that you would want to use to give them if they are suturing a vessel. So that's kind of cool. Here's a PDS. PDS is usually used to suture deep. So like to close when you do abdominal surgery, they'll use this for the first layer. And then, yeah, Ethelon reverse cutting, that's a lot of times on skin. That's what you'll see on the outside if people have sutures, individual sutures on the outside. Ooh, here's something kind of cool. Does anybody know what this is? So I don't have the instrument that goes on it, but this is for a bipolar. So it's like a forceps that's smooth on the outside. USB charger. Yes, it is USB charger. So you put this on the outside. It's like a hemostat or something like that. But it will. They also use this actually for tonsillectomies, but it can be used on delicate tissues and stuff to cut. So it's kind of like a bovie, and then they hook this up to a machine right here, and then this goes off the field and this goes on the field. I think as a nurse, that's also something like super important to remember is like you have all of these things being thrown off to you at the beginning of the cases. You'll have like suction, bovie, bipolar, like all this stuff. So just remember where it all goes in the machines. But anyways, I think my time is up. So I will let you guys go. Thank you so much. I had a chance to assist a physician on Sicilian. Yeah, it's super cool, right? It's awesome. So did you like scrub in and everything like that? I guess probably if you were assisting. But anyways, thank you guys so much for joining me. Have a great day. You too. I'm not sure how to end this, but.
Do you want to walk out of the NCLEX exam feeling like you just walked out of a first grade spelling test? Hang out for a minute and I'm going to show you exactly how you can do that. Alright, so the NCLEX is based on a few algorithms and rules that make it different from anything you've ever taken before. But first of all, you gotta know that the NCLEX is a Computer Adaptive Test, or CAT. What that means essentially is it bases what it gives you on question 2 on how you did on question 1. So if you got question 1 right, it's gonna give you a little bit harder question on question 2. If you got question 1 wrong, it's gonna give you a little bit easier question on question 2. So that means that every single nurse gets a completely different NCLEX because it changes with every single question that we take. Now that can feel really intimidating because we've never taken exams like this before. So it uses a couple different algorithms and rules to make this computer adaptive testing work. The first algorithm to understand is that the NCSBN, who administers or writes the NCLEX, has a passing standard. That means that you must score above that passing standard to get your RN. If you score below it, that means you failed the exam and you must retake it to get your RN. So before you even walk in, there's a passing standard that you must score above. Now, how do you score above that? The second algorithm you need to know is something called 95% confidence interval. What that means is the NCSBN is always trying to determine within 95% confidence where you're going to score or how you're going to answer a specific question. So when you go in there, your confidence interval is really wide. Everyone starts with the same one. It delivers you a random question, and as you get that right or wrong, that confidence interval starts to close. In order to pass the test, that confidence interval must get above the passing standard. If it doesn't, you fail the exam. So because of this, it doesn't matter how many questions you get, it doesn't matter how long it takes. All that matters is that confidence interval, or how certain the NCSBN is that you'll get a question right or wrong, must be above the passing standard in order to pass. So now we understand computer adaptive testing, we understand passing standard, we understand 95% confidence interval. Well, what are they going to ask us? Okay, the NCSBN is going to deliver you questions from 4 different categories broken out into a total of 8 subcategories. Okay, so the first thing they're going to test you on is safe and effective care environment. How well do you create a safe environment for your patient? The next thing they're going to test you on is health promotion and maintenance. All right, are you promoting health for your patients? Are you helping them maintain their health? Then it's going to test you on psychosocial integrity. How are we taking care of our patients' psychosocial environment and abilities? Then it's going to test you on physiological integrity. Things like basic care and comfort, pharmacological and parenteral therapies, our medications, reduction of risk potential, and physiological adaptation. So in total, we're being tested on 8 subcategories, with most of the questions coming from management of care. That's the biggest category, with 17 to 23% of your questions coming from that category. So whether or not you're getting questions right or wrong, it's still going to be delivering you questions in these 8 subcategories in different percentages. So now we understand the basic algorithms that run this computer adaptive test engine. Let's talk about some of the rules then that help feed into these algorithms. The first is the number of questions you're going to get. For NCLEX RN, it's going to be anywhere from 75 to 265 questions. It's also limited to 6 hours. You can't go beyond 6 hours. If you hit 6 hours and you're not done with the test, or it hasn't been determined if you passed or failed, you automatically fail. Then you also get a couple 15-minute breaks during the test. So I recommend after 75 questions, regardless of result, if it goes to 76, take a break right there and just get your mind out of that whole thing that it didn't end at 75, and don't worry about beating yourself up, just take a break. So a couple other things that we get, guys, we get a few FAQs, a couple general questions about the exam. One of the ones we get is, does it test you on generic or brand names of drugs? It's always going to test you on generic names. It doesn't care that you know Tylenol, it wants you to know acetaminophen. All right, so focus on learning your generic drug names. The other one is, do you get a test report after you pass or fail, or when you walk out of the exam? The answer is no. The only time you get a test report is if you failed the exam, and all it's really going to tell you is you were near passing in this basic care and comfort, you were below passing in pharmacological therapies. So it doesn't give you a ton of help, but it lets you know if you're near passing or if you passed. I suggest focusing on those areas that you were near passing and just try to bump those up a little bit to get yourself to pass. The other question we get is, does it bold any words? And yes, it does. It bolds words like best, first, priority, things like that. So really pay attention to these bold words, because it's going to help you know it's a priority question that you must focus on that word. One last question we get a lot of times, guys, is, are you allowed to skip questions? The answer is no. You must answer every question in order to advance to the next question. All right, so that's some of the basics of how the NCLEX works. Now, guys, do you want to know how to get better at anything in life? The answer is practice. I know that's not a sexy answer, that's not some fancy answer that you're probably hoping, but the answer is practice. You can't expect to be an expert skier the first time you get to a mountaintop. It takes time, dedication, focus, and attention. So why should it be any different for the NCLEX? If you want to walk in and dominate the NCLEX on your first try, you've got to practice. Now, while practice banks and test banks are good for general practice, it doesn't give you that real testing environment that is gonna help you walk in and just know you're gonna dominate on that first try. That's one of the main reasons we built our patent pending, completely revolutionary computer adaptive test called NCLEX. This is the only test of its kind. We built this so that you can walk in fully confident on NCLEX day that you know exactly what to expect and that you're gonna walk out passing the test and get your RN. Let me ask you a couple questions. Are you completely confident that you're going to pass the NCLEX on your first try? And how confident are you that you know what to expect when you walk into the NCLEX? Now, I've been sitting exactly where you're sitting right now. You're either a nursing student starting to think about the NCLEX, or you just graduated and you've got your NCLEX scheduled. Either way, you've spent tens of thousands of dollars, time, money, sacrifices to get where you are, but there's 5 letters standing in your way, NCLEX. So let me introduce you to NCLEX and show you 6 reasons why NCLEX is the best way to prepare for the NCLEX. Reason number 1, adaptive testing algorithms. Just like all those different algorithms that I showed you in the beginning, NCLEX does all of that. This is a huge task, and this is why we're the only ones doing this. Because it's hard, it takes a lot of time, but we're doing it for you guys so that you know exactly what to expect and see all those different adaptive algorithms before you ever take the real NCLEX. Reason number 2, all the same rules that apply on the NCLEX apply on the NCLEX. We've got the question limits, the time limits, the bolded words, all the same things that you're gonna see when you see that test screen for the first time when you go in to take your NCLEX. Reason number 3, 6,000 plus questions. Every single question in the NCLEX question bank was written by an NCSBN trained question writer. And it's been vetted by hundreds of thousands of nursing students just like you. This not only makes NCLEX the largest nursing question bank, it also makes it the most accurate way to prepare. Reason number 4, detailed analysis and rationales on past tests. What good does it do to take all these practice questions if you don't know how you're doing? For every question inside NCLEX, we give you a detailed rationale of how you did on that question and an overview of how you're doing on each test. Reason number 5, alternate format questions. The NCLEX doesn't just give you 4 answer options and let you decide between those or true, false, or anything like that. It also gives you select all that apply questions, and it gives you hot image questions and things like that. So we built those question types into NCLEX so that not only do you get the same environment and same algorithms, but you also get the same question types that you're gonna see. And reason number 6, you can know exactly what to study next. With each full test review, we tell you how you did by each NCLEX category and by nursing categories. So you can see that you did really well in cardiac maybe, but you did really poorly in OB. You can go back and study different courses and different lessons on that. Are you ready to feel fully confident that you're gonna pass the NCLEX? I want you to walk into that test day like it's a first grade spelling test. That's the reason NCLEX exists. Head over to nrsng.com to check out NCLEX and read reviews from students just like you who have used NCLEX and passed NCLEX. I know you guys can do this. I want you to go out and be your best selves. Happy nursing. Today, I'm going to show you how to increase your lowest grade in nursing school by over 10% with our 5 proven test-taking tips for nursing students. In fact, these are the same strategies I teach to over 250,000 nursing students inside our NRSNG Academy test-taking course, where 50% of NRSNG students saw their lowest grade improve by an entire letter grade and 25% saw it improve by 2 letter grades. I'm Tormund.
Gather the elders and let's talk.
I'm John Hawes, RN, founder of NRSNG. And in this video, I'm going to give you my top 5 test-taking hacks for nursing students step by step. So keep watching. Did you know that in 2018, 87,371 nursing school graduates failed the NCLEX RN? That's more potential nurses than there are hospital beds in Alabama, Alaska, Arizona, Colorado, Connecticut, Hawaii, Idaho, Iowa, Kansas, and Kentucky combined. At NRSNG, we have a 99.42% NCLEX pass rate. The difference? It's our process. And today, I'm going to share with you 5 of our best test-taking strategies. Now at the end of this video, I'm also going to give you a cheat sheet with 11 test-taking tips, and I'm going to jump on the computer and do some practice questions for each of these tips. So hang on till the end. All right, let's kick these 5 tips off with tip number 1, which is understanding nursing priorities. Priority nursing questions can be terrifying as a nursing student, but think about it this way. When you show up for your first shift as a nurse, you're going to have a task list that's 3 miles long of things to do, and they all need to be done now. So let me show you how to answer nursing priority questions and think about priorities in your real life as a nurse. The most common tool taught to nursing students to address priorities is Maslow's hierarchy of needs. Now, while this is super thrilling to learn, I want you to forget about it when it comes to nursing priorities. Don't tell your professor. Instead, we're going to use what we call the ABC's DEF staircase, which stands for airway, breathing, circulation, safety, discomfort, education, and feelings. This simple mnemonic will help you remember the proper order for your nursing priorities. If a patient just fell out of bed, but they aren't breathing, do I worry about getting them back in bed or educating them on proper call-out use? No, I worry about their airway and their breathing. Now with that, it can be tricky to remember the difference between airway and breathing. Think of it this way. Airway means getting air into the lungs. Breathing means gas exchange of that air. One area you might get tripped up with nursing priority questions is when to call the provider. These answer options can be tempting because sometimes we'll think, well, I don't know what to do. Let me just call a provider and let them worry about it. But there's a better way to approach these options. Anytime you see call the provider as an answer option, think, if I leave my patient's room right now to go call a provider, what happens to the patient? Is there something I can do within my nursing scope of practice? And if I don't do that and leave, what happens to them? Don't call the provider until you've done everything you can within your scope of practice to make sure the patient is okay. Now it's time for the second tip of this list, the SATA success pyramid. SATA stands for select all that apply. You know, the ones that say select all that apply and then have 3,000 options listed. For many nursing students, these are the bane of their existence. But have no fear, SATA questions can be answered very easily using the SATA success pyramid. And it's a super simple 3-step process. When you realize you're answering a SATA question, the first thing that you do is you cover all the answer options, whether with your hand, a piece of paper, whatever. Then you evaluate each answer option individually, physically moving your hand down or your paper or whatever it is. Lastly, as you evaluate them, you turn each question into a true-false statement. Where most nursing students fail with SATA questions is they read answer option A and think, well, that's really similar to B, but it's also kind of like C too, so they begin trying to force answer options to work together. When you isolate each option and make it a simple true-false statement, your success rate for SATA questions will skyrocket. Now, are all select all that apply higher level questions on the NCLEX? Well, yes and no. While it isn't required that SATA questions be higher level of difficulty, generally speaking, SATA questions are going to require more analysis level thinking, which is the higher level of Bloom's taxonomy. Now, if you're thinking, what is Bloom's taxonomy? Check out this short video, wherever it appears, where we discuss Bloom's taxonomy. Now, don't get too caught up worrying about difficulty level or how many SATA questions you've seen. Just apply the SATA success pyramid on your next exam and watch your scores climb. All right, 2 steps down, 3 to go. I hope you guys are feeling better. I don't ever want you to hear again.
While that is correct, it is not the most correct.
No! What does that even mean? All right, guys, with that, let's jump into tip number 3, which is absolute words. When it comes to nursing tests, absolute words are absolute red flags. Don't pick these answer options. Examples of absolute words are always, never, none, all, and every. If you see one of these words, run. Why is that? It's because no 2 patients are the exact same. It's near impossible to say that you should always do the exact same thing for every patient. Now with that, let me give you 2 exceptions to this rule. If it's a safety issue and it can be applied to many types of patients' populations. And let me give you a specific example of that. If an answer option says, never lift a Foley bag above the bladder. Is this a safety issue? Well, yeah, because we don't want to cause a UTI. We don't want that backflow and cause a UTI. And can it be applied to many kinds of patients? Do we lift a Foley bag above a pediatric patient? No. How about on a geriatric patient? No. It's really that simple. I know you're never going to forget that tip. All right, tip number 4, stay true to the nursing process. You might hear the nursing process slightly different from what I'm going to share with you, but essentially, any way you hear it, it's saying the same thing. Assess, diagnose, plan, implement, and evaluate. Never break this process, ever. Never, never, ever. Now, I don't want you to overthink the nursing process. This is basic stuff. It's really the scientific method you learned in elementary school, but we're just applying it to nursing, and we use it in our everyday lives. Look at an example. I wake up in the morning and check the weather. It's cold, so I plan my outfit. I put a sweater on, I go outside, and it's a bit warm, so I start the process over. Change my outfit. It's really the same with nursing care. You don't skip a step in the process. Don't start doing things on your patient until you've assessed, made a diagnosis of the situation, and made a plan. I'm not going to beat a dead horse on this tip, but just learn to appreciate the nursing process and the structure that it provides to you as a nurse, and remember to never skip a step. Never, ever, no matter how good an answer option might appear. All right, lastly, tip number 5, don't fall for NCLEX question traps. Every now and then you're going to come across an infamous NCLEX question trap. Look, the NCSBN, who administers the NCLEX, wants to be sure that you're a safe nurse and that you don't cause any harm to a patient on your first day as a real nurse. To do this, they use a couple little traps to see if you really know the nursing process and if you're willing to slow down and make the right decision, not just any decision, to do something for your patient. So here are 5 traps that you can avoid on the NCLEX and in nursing exams. I'll list them and then give you some examples. No assessment, incomplete assessment, first doesn't always mean assessment, action doesn't always mean implementation, and determine the outcome for each answer. Let me give you some examples of these. No assessments complete. I used to see this a lot when I worked in the hospital as an RRT nurse, where I would rapid response team. We would get called a couple hours after blood sugars were checked and insulin was due. A lot of times we would arrive, take the blood sugar, and see that the patient's sugars were below 20. Even in the teens, sometimes even below 10, the patient was unresponsive. As we would look at the MAR, we would realize that what had happened is the tech had checked the blood sugars. Then a couple hours had passed. The nurse came and administered insulin based on blood sugars from a couple hours ago. No assessment had been complete and the patient was put into danger. Another one is incomplete assessment. An example of this might be, you see a question that says, you're taking care of a diabetic patient. You walk past the room and the patient's shaking. And one of the answer options might be, administer D50 immediately. That can be tempting because we want to get those blood sugars up. But we haven't even completed a full assessment. The first thing we need to do is check blood sugars. This patient might be an AFib or they might just be cold. Number 3 here is first doesn't always mean assessment. This is really a semantics thing. We've got to separate our mind from the first is always assessment. While it's the first step in the nursing process, if they say, what would you do first? Realize where you are in the nursing process and what the next action should be. With that leads into action doesn't always mean implementation. With the example I gave before, the first action would be complete your assessment, get a blood sugar. So just separating first and action from assessment and implementation. Then lastly, determine the outcome of each answer. When you read an answer option and you think about selecting it, think, if I do this and then clock out and drive home, what happens to my patient? What's the outcome for that patient? Is it going to be good or bad? And only select those things that keep your patient safe. You can pass nursing exams and you will pass the NCLEX. Inside NRSNG Academy, we help you cut the fluff, improve your exam scores, and feel better prepared for life as a nurse. Click the link in this video and in the description to get a full list of 11 test-taking tips for nursing students and to check out our test-taking course. Now lastly, let's go jump on the computer and I'm going to show you examples for all 5 of these steps. These example questions are coming from a book called Test Success by Patricia Nugent. I highly recommend you head over to Amazon, grab yourself a copy. It's a really great book and it will greatly help you in nursing school. This first question says, what should be the nurse's first action before administering an enema? Verify the physician's order, collect the appropriate equipment, arrange for the bathroom to be empty, or inform the patient about the procedure. All right, what tip can we use here? Well, if we look at first action, we realize this is a priority question. It's wanting to know, do we understand nursing priorities? So we've learned that we can use the ABCs, DEF, and we can also use the nursing process here. So verify the physician's order. Is this an ABC, DEF? Well, yeah, sure. This is a safety issue. Collect the appropriate equipment. That goes into nursing process. That goes into like implementation. Arrange for the bathroom to be empty. If we think ABCs, DEF, that's a feeling thing. We want the patient to feel safe and to make sure that they're okay. And then 4, inform the patient about the procedure. ABCs, DEF, that's education. So our top one here was a safety issue. Then we had feelings, we had education, and we had implementation. So if we go back to our ABCs, DEF, as a safety issue, this becomes the most important one, and we should select number 1 to verify the physician's order, make sure our patient is safe before all else. All right, example number 2, a patient is receiving oxygen by nasal cannula. After morning care, the patient experiences dyspnea and complains of feeling tired. When planning for the patient's bath the next day, the nurse should plan to give a complete bed bath quickly, bathe only the body parts that need bathing, arrange for several rest periods during morning care, or continue with the same plan of care because we don't care if our patient dies of dyspnea, because dyspnea is unavoidable. All right, so let's look at the question here. When planning for the patient's bath the next day, the nurse should plan to. So this is really testing us on our nursing process. So remember, we're talking ADPIE, assess, diagnose, plan, implement, and evaluate. Which phase of the nursing process is this testing us on? A patient is receiving, the patient experiences dyspnea, feeling tired. When planning for the patient's bath the next day, the nurse should plan to. So we're in the planning phase. This wants to know, do we understand everything that's involved with the planning phase? Give a complete bed bath quickly. That's kind of implementation. Bathe only body parts that need bathing. Also implementation. Arrange for several rest periods during morning care. Arrange, that sounds like planning to me. Continue with the same plan. Well, that's not even a safe thing. So we can cross that one off immediately because our patient's not going to be safe. So option 3 immediately goes back into plan and planning. And we would select that option because it is during the planning phase of the nursing process. All right, let's do one more example. How can the nurse best improve circulation when giving a patient a bath? Apply soap to the washcloth. Keep the patient covered. Use only hot water. Use firm strokes. What immediately stands out to you in this question? The word only should stand out to you. If you remember, we talked about these absolute words, always, never, none, all, every, only applies there as well. We can cross out option 3. So immediately we went from a 25% chance of getting it right to a 33% chance just by crossing out this absolute word. Now, apply soap to the washcloth. That obviously doesn't improve circulation. Keeping the patient covered and using firm strokes. Now we're at a 50-50 chance of getting this question right. Now, the correct answer would be using firm strokes, helping with the circulation, helping the blood pump, and that's going to be the best way that we can improve circulation in our patient. All right, guys, that is all the practice questions that I have for you to quickly apply these strategies and these tips that we discussed today. If you guys want additional help, please head over to nrsng.com. We've got 6,000 practice questions with the most detailed rationales on the planet. You guys can achieve this. You guys can do this. You're going to become a nurse. And as always, like we always say here at NRSNG, go out and be your best selves today. Happy nursing.
What's going on, everybody? My name is Brad, and welcome to the end of NRSNG Live. It's been a long day. For a lot of you guys, I'm sure you've been up since like 5, 6, 7 a.m. A lot of you guys have traveled to be here. It's so awesome to see you guys. You actually paid money to come out here to try and better yourself and become better nursing students and future nurses, and that's awesome. Real quick, guys, can we get a round of applause for this man right here and all of these wonderful people who put on this awesome conference? The guy's a beast. What I wanted to do, I'm not going to take up a whole lot of time. They gave me 45 minutes to speak. I'm probably not going to need that much because this is the end of the day and I know you guys are tired, and I'm excited to get into some questions from you guys. So what I wanted to do is I wanted to introduce myself, let you guys know who I am, and then what I wanted to do is I wanted to give you guys 5 tips to try and help you guys cultivate a successful state of mind, to help you guys be good nursing students, but also good nurses as well. So to tell you guys a little bit about me, my name is Brad Bass. I am a registered nurse. I graduated in 2016, and I passed the NCLEX and started working early 2017. Whenever I first came out, I initially started working as a new grad nurse in the cardiothoracic surgical ICU. I've always had a passion for critical care, and so I wanted to dive into that. Got a lot of experience, a lot of hands-on. Did that for about 2 years. It was around that time that, it was in 2017, I believe, lost my mother, and then in the same year lost my father and had a son. So I had a lot go on, a lot of changes. The loss of my parents led me to change career paths. So, you know, I love critical care, but going into the ICU and then dealing with death, it got to be a little bit too much. So my wife and I relocated back home towards our family, and I started working in the OR as a circulating nurse. And I'm also working as a scrub nurse as well. I get to actually scrub in, be one of the sterile members of the operation and work right alongside of the surgeon. We're going through our rotations right now, and I just completed my cardiovascular OR rotation, and I got to hold a heart on Friday, which was actually pretty awesome. You get to do a lot of stuff as nurses, man. There's a lot of things that you can do. Anyway, so I love cardiac, and hopefully I'll end up in the CVOR. But that's a little bit about me professionally. To tell you a little bit more, I have a YouTube channel. It's Nurse Bass. I started that around 2014, I believe, when I was still completing prerequisites, just as an opportunity to document my journey, kind of have a video diary, if you will. So whenever I was done with my nursing school program and I was out working, I could look back and see, that's what I looked like on my first day of nursing school. People ended up liking it, people ended up following and subscribing, and then my mission did become the grind. The passion became the student, and that's what I've been preaching ever since. So what I wanted to do, give you guys 5 tips. Like I said, I'm going to try not to take too long, to help you cultivate a successful mind state. So the first tip is the self-fulfilling prophecy. My interpretation of that, some of you may know what that is, but my interpretation of that is the mind manifests itself in the physical. So I want you to think about that. The mind, what you think and believe, literally materializes in your physical environment around you. It's kind of similar to the believe something into existence thing. Sounds a little cliche, but it's very true. You're presented with set of stimuli all the time in life. You're presented with set of challenges. And the true test of your character is how you react to those challenges. You can either react positively or you can react negatively. So to give you guys a little example, imagine it's like 4 or 5 in the morning. It's dark, you're half asleep, you wake up, you gotta pee, right? Your bladder's full, you're like a nurse on a med-surg floor, it's about to pop. You wake up, you go stumbling through the darkness into the bathroom, and you stub your toe. I don't know if you guys have ever stubbed a toe. I have, and that's kind of like a deal breaker for me. That's the kind of thing where I'm gonna go get back in bed, I'm gonna roll over and call it a day. It's a stupid example, but it's an example of being presented with some kind of small stimuli that's negative, and then it's like, how do you react? So how does this relate to nursing school? I saw a meme on Facebook the other day, and it said that you can react one of 2 ways when you're presented with a difficult situation. You can either look at it like I have to, or you can look at it like I get to. It's a very important distinction. And why it's so important with the self-fulfilling prophecy thought is that the way in which you respond to these small things permeates the rest of your life. It bleeds out into your nursing school career, and it's going to bleed out into your career as a nurse. So you guys are nursing students. You got a lot on your plate. You're inundated with things that you have to do, tasks that you have to complete. You know, you can look at it like, man, I got to get up at 5 a.m. I have clinicals at 7. I'm going to be there for like 10, 12 hours. Then whenever I get off, I got 2 care plans that I got to do. You know, Mrs. Smith, I passed 20 meds on her. That's 20 med cards I got to do now. You can look at all these things like I have to. Or you can look at it like I get to, right? So I also want you guys to do a little bit of reflecting, those of you who are actually in nursing school right now. I want you to think about everything that you had to do to get where you are. I want you to think about all of the hard work and sacrifice that you've had to make. A lot of documentation and paperwork that you had to submit to get into nursing school. The entrance exam, all the prerequisites you had to complete, and you got in. You are the chosen few. But I also want you to think about the people who didn't get in. People who worked just as hard as you did. They completed all the documentation, prereqs, entrance exams, and they got the rejection letter in the mail. I bet you anything that they would give anything to be in your shoes, to have the opportunity to learn about pharmacology, to learn about patient assessments, to get hands-on. That's their dream. It's all of our dreams. But they didn't make the cut and you did. So I just implore you guys to look at every day, every opportunity to get on the clinic floor, to learn, to go to lecture. Look at it as a blessing. Look at it as I get to instead of I have to. Second thing that I have for you guys, tip number 2, is surrounding yourself with like-minded people. Look at everybody in here. You all collected here for the same purpose. You all have that grind mentality. Surround yourself with like-minded people. It's going to set you up for such success in nursing school and then beyond. Now, you guys are going to have to forgive me because I'm going to tell a couple of stories today during this talk. But I first learned this lesson whenever I was still in prerequisites. I was in my anatomy and physiology class, and so for those of you that haven't been following me, as far as prerequisites go with AMP1, AMP2, and micro, I killed it, right? I did better in those classes than I've ever done in any other class. So I'm in AMP1. We have our first exam. I do well. I don't remember what I scored, but I scored really high. And I sat in a table with my, you have AMP, the class, and then you have lab. So I'm in lab, and the people who sit at my table, they were strangers to me when the semester started. I got to know them. We became cordial, and we became friends. They saw how I did on the first exam. They also saw that I was asking a lot of questions, and then whenever the professor would ask questions, I would answer them appropriately. So what they wanted to do, they asked me if I wanted to form a study group. And I'm like, cool. I mean, that sounds good. I didn't know how they were performing in class, but I thought, if nothing else, it'll give me an opportunity to sharpen the intellectual sword, if you will, and then, maybe I'll be able to give them a little bit of tutoring and help, something like that. Anyways, we got into this study group, and I'm sure a lot of you guys have probably been in a study group like this. It quickly turned into a socialization kind of thing. We weren't there to talk about the work that we were studying and everything that was important. It became more about like, did you see that Lane won American Idol? I don't know how many of you watch American Idol, but Alejandro should have won. Or Arya and the Night King, whatever it might be, it just becomes about socialization. And then as a result, it gets reflected in test scores. So I can't express to you guys enough the importance of surrounding yourself with people who have that same mentality, that same grind, who understand what we're doing here, right? You're paying all this money, you're sacrificing all of this time in the pursuit of a dream. And you did everything that I've already talked about in order to get into nursing school. So surround yourself with people who are going to take it seriously and treat it as such. Third tip that I have for you guys is auditing yourself. I have to give a shout out to Gary Vaynerchuk for this. If you guys don't know who he is, he's a serial entrepreneur, a very successful guy. This is something that I kind of implemented into my life when I was in nursing school without even realizing what it was. It was only once I heard him articulate it out that I realized what auditing yourself means. And essentially what it is it's a self-analysis process. It's a tool, something that you can add to your arsenal to help you deal with difficult times. Whenever you don't perform as well as you wanted to, you failed a test, failed a skills assessment, dosage calculation, whatever it might be. So, another story. I was in my first semester of nursing school. Like I said, just came out of all my prerequisites. I was killing it. I was cocky. I was like, man, I just made straight A's in these most difficult of courses. I was feeling good, feeling on top of the world. But I also knew how difficult nursing school was. My wife is a nurse also, and she had graduated before I ever began the program, so I saw how difficult it was. So I'm like, I got to take nursing school seriously. This is a serious thing. Get into my first exam, and I got a high B. It was like 2 points away from an A. And that, me being an idiot, that just further fueled my cockiness. I'm like, I just killed it. Nursing school is supposed to be so difficult, and here I am, I almost made an A. So I'm like, cool, man, I'm sitting pretty, I'm doing okay, this isn't a big deal. And whenever it came time to prepare for the second exam, I had learned about Game of Thrones. Any Game of Thrones fans in here? Anybody? We're not going to talk about the 8th season. But I had just gotten into it, and I binge watched in like a matter of 2 weeks, like the first 3 or 4 seasons. Just cocky, stupidity, underestimating the beast. And it came back to bite me. Whenever the second exam came around, I was 2 points away from a D this time. Bombed it, man, bombed it. And that was humbling. That was really humbling. It's like the slap in the face that I needed. So what did I do? I audited myself. I'm like, what's wrong? What's going on? And obviously I shouldn't have binge watched Game of Thrones. But that's the kind of thing. It's the continual refinement of your process. What are you doing? What went wrong? What could you have done better? Is it your note-taking? Is it how you absorb lecture? Are you not asking questions? Are you not asking questions or reviewing the exam after the fact? Whatever it is, I cannot stress the importance enough of continual self-analysis, because it is that continual refinement of the product that is you. And whenever you sit back and you look at it, if you're not pouring the majority of your time into your craft, you're doing yourself a disservice, and you're doing your future patients a disservice. So just a little tool that you can add to your tool belt whenever times get hard, because times are going to get hard. Anybody out there who's in nursing school right now can attest to that. A lot of people say it's the most difficult thing you'll ever do. So I'm just trying to give you a little something that you can use to deal with these difficult times. Fourth tip. Fourth tip is remember your why. Very important, very important. A second tool that you can add to your tool belt whenever times get hard. Not only is nursing school difficult, but once you graduate and you become a nurse, it's a difficult profession that we're in. We are a chosen few. So whenever times get hard, always remember your why. Why did I get into this to begin with? We all have different reasons. Some people say that they just want to help people. Some people want a financial career, financial stability for their family. Whatever it is, never forget your why. It's going to help carry you through the hard times. Please believe that. And the fifth and final thing, I'm going to spend a little bit more time on this one because it's the one that I'm most passionate about, is to remember the why. Remember why you're doing this to begin with. Why are we even here? Why is everybody collected right now in Allen, Texas? Why is John working as hard as he is? It's the patient. That's what we're here. That's what we're doing. The end goal is to be the best nurse that you can be, so that when it's just you in that room and you don't have the fine folks at NRS&G and you don't have your clinic instructor, you don't have a preceptor there with you, and it's just you and that patient, that's why we're doing this. I got a quote that I say all the time. Some of you may know it, some of you may not. One day, patient lives will be in your hands. Study like it. Couldn't be more true, right? Do some self-analysis, right? Audit yourself. Would I be comfortable with a nurse studying as hard as I am, taking care of me, if my life was on the line? Am I studying that hard? Am I pouring that much into my craft? And if I'm not, let's do something about it, right? So I'll tell you guys another little story. Whenever I started as a new grad, like I said, I started working in the cardiac ICU. So I had, a couple of months of training in ICU where I rotated through different ICUs. And then I also, once I got hired into the cardiac ICU, I had a few months of training there, always with a preceptor, never by myself. Well, I want to tell you a little story about the first time that I ever had to care for a fresh post-op open heart patient. A new grad, a baby nurse, don't forget. So whenever these patients come back, in my ICU anyways, there's usually 4, 5, 6 nurses who were there waiting, gloved up, ready for this patient to come back. And I got to give a shout out to my 2 South nurses. You guys won't know about that, but they really helped train me, some of the smartest people I've ever met. When this patient comes back, they look dead. They are intubated, breathing tube down their airway. They're sedated. They've got a bunch of different peripheral IVs. They're on a ton of drips to keep them sedated, to manage their blood pressure. They have chest tubes, blood coming out of the chest tubes into a canister. They have epicardial pacing wires that go through the skin into the pericardial cavity and actually attach to the heart so that we can manage their heart rate. All of these things in this one patient presentation coming right through the door to me. Never done this by myself before. This is my first time. Whenever these patients first come in, there's 5 and 6 nurses in there because it's chaos. It's like a NASCAR team. Whenever these patients come in, we've got people drawing labs. We've got people collecting urine and chest tube output. The patient, we're hooking them up to the monitors. We're getting vital signs on them. They're incredibly unstable. Their blood pressure waxes and wanes. We're administering medications, things like that in like that first 20-minute period. So I've got help in there. I'm cool. I'm feeling kind of confident because I've got people around me who are vets. They've been doing this. After 20 minutes, though, everybody leaves. Everybody leaves once we got the patient completely hooked up to the monitor and everything, and they all leave, and it's just me. And I'm seeing all of these things I just described to you in this patient, and I know that there's nobody else in there but me. And like I said, they are so sick and so unstable, it's crazy. And then for the next 6 hours, we're administering all kinds of medications. We're titrating the epicardial pacing wires to get the heart rate right where we want it. Blood products, albumin, all of these things that we're slamming on this patient that I'm doing by myself to keep them alive. And this is somebody's loved one. You know, never forget that we're in the human lives business. And so I can't describe to you that feeling of being the only one in there. All I can do is tell you about it. But it's in that moment, it was in that moment that little quote, study like it became more real than ever. It was at that point in time that I was so thankful that I sacrificed all those hours, that I learned the anatomy and physiology the way that I did, that I actually put forth the effort to be the best nurse that I could be. I'm going to give you guys one more story, and I'm leaving y'all alone. This is like a little parable that was told to me a long time ago. I first heard it at my wife's graduation, and I thought it would be a nice one to share. Some of you may have heard it. Some of you may have not. It's about a wise man and the starfish. So this is how it goes. Wise man was walking down the beach, and beautiful beach, hot day. As far as the eye could see, down the left side of the beach and down the right side of the beach, as far as this guy could see, this beach was lined with starfish. And he saw a woman on the edge of the water throwing starfish back into the ocean. He was curious. He didn't know what was going on. This guy's wise, very smart man. He goes and he approaches the lady, and he says, "What are you doing?" And she said, "Well, all these starfish have washed up on the shore. If they're left here, the sun's beating. They're going to dry up and die. So I'm trying to save these starfish." The wise man, once again, looked down the left and the right side of the beach, and again, as far as he could see, it's full of starfish. And he looked back at the lady, and he was just kind of laughing, because he's such a wise guy and above everybody. And he says, "What are you doing? This is pointless. This is futility. There's no possible way that you can make a difference. Look how many there are." The lady reached down, grabbed another starfish, threw it into the ocean. She looked at the wise man and said, "I made a difference for that one." Ladies and gentlemen of NRSNG 2019, go be the difference. Thank you, guys.
So our next segment will be a Ask Me Anything panel by 3 students, well, 2 recent graduates, 1 fourth-year student. We asked those who were participating to send in some questions, so I have a list of questions that have been submitted on how do I survive nursing school. After I've asked the questions that have been submitted, if you have things that you're thinking about and questions you'd like to ask the panel, then we will go ahead and open up to you guys. So our panel consists of Robin, who can come on up here. Robin is a recent graduate from El Centro. She is currently working at Methodist Hospital. She'll be taking the NCLEX on Wednesday, so you can text her on Wednesday to find out how she did. She'll be continuing at A&M for her BSN, and she did all of this as a mother of 6 children. So she'll have a lot of insight on balance. Heather, who just graduated from UT Tyler Palestine. This is Heather's 2nd career. She was for 10 years in the Army as a geospatial engineer. And she'll be taking the NCLEX at some point in the future, and she doesn't want you to know when. And then Jonathan, who is at Collin College. He is an inductee into the Alpha Delta Nu Honor Society. He's class president there at Collin College, and he is in his 4th year. So thank all 3 of you for being willing to help us out. So guys, I will ask the question. Any of you or all of you can answer them. If none of you want to, I'll select one of you to do it. Our first question, and you'll notice there's a theme to a lot of these questions. A lot of you have a lot of the same concerns that are going on in your mind. So the first question, what is your best method for studying for exams?
Initially study all of it at a basic level. So do like a quick survey of all the different topics. So like I've got a test coming up this week and it's over clotting, immunity, and metabolism. And what I've done in the past sometimes is I would try and study everything for clotting. And then I'd be really good at clotting and know all that. And then metabolism or immunity, one of them would really hurt me on the test. So I try and study the core content. You can use NRS&G has actually been a great tool for me to say, like, you know, what's the most important information and get that for all of it. Then go back and study the details. Depending on the format of your program, for us, like we have our PowerPoints that we cover in class. So I'm going to do all the PowerPoints and then go back and read the textbooks and get the extra details and what I need there. If I try and read, again, I'm going to do all the readings for one topic and then might skip over some of the extra details or some of the more important information for those other topics. So I try and do like a brief survey of all the material, and then as I go back and study it all again, go a little bit deeper, and then a little bit deeper with the time that you have. Because you'll find out if you're in nursing school, you already know, or if you're taking your prereqs, you'll find out once you get there. It's a really busy time. So trying to get the most important information and then get the details the second time through is my biggest suggestion.
Heather, Robin, anything to add?
As they mentioned, I have 6 kids, so time is really limited for me. I also work continually full-time as a surgical tech at the hospital the whole time. So I honestly, I'm gonna confess, never opened up my digital textbooks that I paid $2,000 for. I found NRS&G my first semester and slowly studied pretty much from there, and then some other online video and stuff like that, because I was a visual learner and didn't have time to sit and read thousands of pages for each exam. But when you're studying for exams, I think the most important thing to do is to not sit there and try to just memorize content. Again, you don't need to know everything, but you do need to know the processes behind it. You need to go back to A and P, the disease process, what are your interventions, and why those work, and what they do to the patient. And if you have a basic understanding of the cycle of how those work, and go back and evaluate, then even if they give you a question that you didn't have the reading for or weren't given the information for, you can use that understanding of the process to answer the questions, which is what happens on NCLEX. You're not going to know everything. You're going to get questions that was never in your textbook, but having that understanding of how the processes work is probably the best thing that you need to know.
Thanks. Heather, anything?
So I'm a terrible test taker. Terrible. I didn't know how to study. I didn't know what to study. I tried every method under the sun to study, and I couldn't figure out what was going to work. I failed Med-Surg 1. I'm going to tell you that's okay. It sucks. It hurts. You cry a lot. It hurts your pride, but you'll graduate. I just graduated in May. So if you have failed, or God forbid you do, I hope you don't, it's okay. And you can get through it. You have to find what works for you, and what works for me isn't going to work for you. But I use NRSNG a lot, and every morning before I went into a test, I reviewed John's test taking tips. But I don't know if he's going to, are you going to go over that today? Yeah. I reviewed him every morning before my test, and it helped me decipher what that test question's actually asking for. And tell yourself you can do it. Like Nicole said, you can. You know it. You just have to believe that you know it.
Thanks. I feel like I have to caveat right now. They were not prompted to mention NRSNG. Like they have total creative control over their responses. I swear to you, right? Like you are not being paid or like anything, right? I promise. Thank you guys. Next question, clinical time management. How do you manage multiple patients? Who wants to take that one?
Her first comment was it's a learning curve, and the honest answer is it's a skill I'm still working on. You'll talk about in class, who's the most important patient, who's the most likely. I think the easiest way to think about it, who's the patient most likely to be the most unsafe the quickest, and that's going to be your first priority. And then you hear also, in class, you might learn about the nursing you will learn about the nursing process, and you'll have your assessment and your diagnoses, and then go through your planning and your implementation. And the biggest thing is taking that from one patient to all of your patients and realizing you're going to want to assess all of your patients, figure out what their status is. And sometimes that first assessment is literally just looking at the patient. You can tell if they're breathing really hard, that's who you might need to go to first, as opposed to the patient that's just sitting there watching TV, talking to somebody else in their room. So starting off with the initial assessment and then moving through where you need to go from there. But again, it's a skill that I'm still working on myself. So give yourself a little bit of a break and realize that everybody has a learning curve that they're going to have to figure out things. And then once you graduate, take the NCLEX, you'll still have that to learn.
Thanks. Anything to add?
I think I want to add that nursing school is a great place to start learning time management. You have lots of classes, lots of projects to do, and then a possible timeline. They're like your patients right now. You learn the skills of deciding what's most important. Is it that paper that's worth 40% of your grade, or is it, the little quizzes that are really worth nothing? And that's when you start learning your framework of how to manage your time, make a schedule, write things down, make a plan for yourself for the day. You learn that in nursing school, and then your framework, you take that once you become a nurse into the hospital and just apply it in a different situation. So right now is the time to start honing your skills of time management and how to prioritize, and then you just take that forward. And then with anything, when you're in a new environment, you have to learn where things are. You're going to be really bad at it at first. You don't know where the linen closet is. You don't this, that. You don't know what the hospital policies are. So you just need to give yourself a break and, think positively that you can do this, and you will get there with practice.
Thanks. Here's a really good question, I think, for all three of you, because of your different kind of backgrounds. How do I prepare my husband, wife, girlfriend, boyfriend, significant other for me going to nursing school?
Good luck. I am a police wife, and he went through the police academy the same time I was finishing up nursing school. We have 2 kids. You need to find your circle or your village, especially if you have a family, that is going to help you. I can't tell you how many times I drop my kids off at my in-laws. Good luck. They haven't eaten dinner. I have a test tomorrow. Sorry. But they all understood. So you need to find somebody that understands, that's willing to help you. And as far as your significant other goes, explain to them. They don't know how hard nursing school is going to be unless they themselves are a nurse or are in nursing school. Explanation. Because if they don't understand it, how are they going to be supportive? So.
Before I ever started nursing school, I just had to sit down and have a talk and say, I don't know what my weekly schedule is going to look like. I hear it's pretty hard. It is. And I just said, I don't know how much time I'm really going to have, how much free time. So it was just preparing ahead of time. And then kind of like you were talking about leaning on your village, the number of times that my little brother, my sister, my parents have had to take my dog out or, just help with the little stuff like that so that I could have the time to study. You're going to find little things, or even just, you might need a vent sometimes. So having those people you can talk to, lining that all up ahead of time and having your support system in place is a really key part of it.
I think just like you have to take care of yourself, you're going to have to make a schedule. You need to schedule time for yourself, for your mental health and your own health. But you need to plan ahead. You're not going to ever just happen to come across free time for your family or your husband. You need to make sure to plan, schedule. I've got Sunday for 4 hours. We're going to go do something that's going to be special and memorable, and that's our time together. And I think that really helps get spouses and family through this. And just also being honest and upfront, telling them that this is going to be very difficult. I've heard from several different places that the divorce rate in nursing school is astounding. So if you're just open and upfront and honest and talk to them and make sure you schedule time for them, it helps. But it is hard.
Thanks, Heather. Thanks, Robin. That actually leads into the next question, which is how do you balance your personal life with the demands of school? Heather?
I think second semester, when I realized everything was going to hell in a handbasket, I had to write everything down. And my planner is timed. It's like a hairdresser's planner. And I had to write out everything that I was going to do. If it was time for my kids' tumble, because my daughter would be like, Mom, did you see that back handspring I just did? Oh, no. Sorry. My head was in my book. Little kids especially don't understand that. So I think you just need to, you have to plan it in there. You need your time, your family needs your time. Yes, you need to study. But if they have their time, they're less likely to, or they're more likely to support you through it. So, I don't know if I kind of missed the question there.
Jonathan, any ideas on how do you balance your personal life with the demands of school?
I think it's important to realize, when you're at a point where you're burned out. And so yesterday, we have a test next week, and I realized, I was studying this the night before, had already been looking at it for a few hours, and I knew that I needed a break, so I went and played golf and just relaxed and took my mind off of things. And then when I got home, then I could really sit down and focus and was able to work. It can be really frustrating when you're trying to go through however many PowerPoint slides, however much reading, all of that, and you feel like you're making no progress, and you look at the page numbers, and it's been however many hours, and you're 3 pages further along. So being honest with yourself and saying, if you're not in the mood to study right now, go do something else for maybe it's just 15 minutes or maybe it's a few hours. But if you're not in the right mindset, that's okay sometimes. And you'll find a balance over time and over the long run to be able to really sit down and focus when you need to.
Thanks. How do you avoid burnout?
It goes back to, again, scheduling time for yourself, whether it's you're going to get your toenails done, or I continue to exercise. It's when you have time restraints to studying, you're like, oh, the first thing that goes like, I'm not going to stop running, I'm going to whatever. But it's really important for you, physically and mentally, to get exercise, to make sure you're hydrating, you're getting sleep. One of the things that nursing students always want to sacrifice is sleep. I always made sure that, as long, working and being a night shift employee, it's hard to get sleep in, but I always made sure that I was rested, especially before a test. Getting sleep is probably a huge one. Don't sacrifice sleep for getting that last few hours of studying in before an exam. It's not helping you. If you don't know it at 5 a.m. before your test, you're not going to know it. So you're going to be better benefited by being well rested.
Just to kind of piggyback off what she said, you need to find something that you love that gets your mind off of nursing and do that. Make time for that, because if you don't and your life is just nursing school, nursing school, nursing school, nursing school, nursing school, as it often feels, you don't have that, I lost the word I was looking for, outlet, and you need that. You need to get away from it and have a little brain reset.
Jonathan, any ideas? How do you avoid burnout?
kind of agree with both of what they've said. You definitely have to make sure that, you're getting you're getting your exercise, you're getting your sleep. This is my second degree, which probably 3/4 of my class is either second degree or second career. There's a wide variety of, some students are right out of high school almost. But when I was starting my first degree, somebody had told me sleep, social life, and good grades. And you get to pick 2 of the 3 and that's it. And that's horrible advice. You definitely need to find time to, when I hear the social life, that can be social life or just any other hobby, something to take your mind off, an outlet. And make sure that you're scheduling the time ahead of time to get all of those things in, because if you leave one of those things out, it's going to start affecting the other, whether it's sleep, whether it's rest. If you're, eating poorly, you can start to feel that over time, any of that. But with all that, that's a lot of things to keep in balance. So one of the things that I try and keep in mind is you're not going to be perfect at everything. You're not going to be great at everything. So pick one thing at a time to try and get a little bit better about. And then once you get a little bit better at that, then you can pick one more thing to get better at. So if it's exercise, focus on exercise for a month, a week, or a few weeks. And then focus on your diet. Don't try and be this perfect person all the time. It's not going to work, probably.
Great, thank you guys. Here's a good one. For somebody who is pre-nursing, what's one piece of advice you can give to them today to avoid the stress? To avoid the stress of nursing school. Okay. Yeah.
Again, I think it's really just finding that time for yourself. And it's going to be stressful. It's going to be hard. So find what you love now and make that a routine and figure out how to keep that routine alongside your nursing school routine that's going to be coming up. Because if you don't have that time for yourself and that outlet, it's going to create even more stress.
Just using, when you're taking your prereqs, so I took mine pretty much 1 or 2 classes at a time. The nursing material, I haven't found as any more difficult than the prerequisite classes. The microbiology or the anatomy and physiology, there's a lot more of it, and you're getting exposure to, like, I'd never worked in a hospital, so the first day of clinical, had no idea what I was doing. I'd been learning the science and the skills and all that, but the environment was totally new to me. So using your prerequisites while you're taking maybe only a few classes at a time, use that time period as like a training period to find out what your learning style is. Practice scheduling everything in. Some people like to 168 hours in a week. Some people like to schedule out every minute or every hour, including free time. That was never my style. I tried it, and it actually caused me more stress. So, figuring out, does scheduling out every hour of my day, is that good for me, or does that just stress me out more? While you're taking your prerequisites, find out about yourself more than just the learning.
I was wondering if I could ask a quick question.
Yeah, go ahead.
Is it realistic to actually have a job while going through nursing school?
So his question, is it realistic to have a job while going through nursing school? Robin, you have a job.
I do. I worked full-time, so 3 12-hour shifts a week at night, on top of going to school. First semester, the way mine was set up was really hard because I think we had 3 or 4 days we had to be down there, and so I ended up working all weekends. It's really an individual thing, and are you able to organize that? Are you able to? It depends also how busy you are at work. I work L&D at night as a scrub tech, so I scrub C-sections, and there's no C-section scheduled at night. It's just whenever someone doesn't progress or whatever. So I have a lot of downtime that I can use for studying, so that's how I managed to work full-time still. Someone who's like a tech in the ER that's very busy and you're going the whole time, I don't know that. It would depend, again, on your personality and your life, what you have outside of school, that you can make that work. But it can be done.
How willing your employer is.
Right. Also, a willing employee is, mine was willing to work with my schedule, and if you're not in school already, I know that my nursing school is very last minute. They'll hand out the schedule and then change it, and it's like, oh, okay, I've got clinical tomorrow morning now. Let me go call my employer. So having an employer that's, willing to work with you also helps you keep your job doing nursing school. So.
I have not worked while I've been in nursing school, but probably over half of our class does in some way, shape, or form, especially as we got further along. some have picked up like tech jobs or that kind of thing. So there's plenty of my classmates that have worked during that time.
For those of you who are in nursing school, show of hands, how many of you are working? So that's a good answer to your question. All right. Any other questions from the audience? Thoughts on your mind? Okay. The next question that we have here is, what is the study method that worked best for you?
So I kind of touched on it earlier, and I'm a visual learner, so reading, looking at PowerPoints, that really helps me. Seeing charts or images. Our textbooks have a lot of the flow charts for like pathophysiology, so those kind of things really help me. But trying to get the most important information, do like a skim through of the textbook or the PowerPoint slides, and then go back and reinforce that, if you will. I always like kind of the first pass, second pass form of learning rather than trying to learn everything about one thing. Because we've touched on it, a lot of nursing style questions are about, as a nurse, you see these signs and symptoms, what's your next action, or what do you anticipate the orders to be? It's not what exactly is causing this at a pathophysiological level. Sure, it helps to know that, and it can help make more sense of why your intervention is going to be what it is, but that's not going to be the questions that you're getting. You're not going to get necessarily asked about, which organ is it that's causing that pain. It's going to be, where might a patient complain of pain? So also, doing a lot of practice questions helps too, to see the style of questions that you're going to get in nursing school and on the NCLEX are different from what you got in AMP probably, or microbiology. So just seeing the style of questions will help you know what information to look out for when you're doing your studying.
Okay. Heather and Robin, what's the study method that worked best for you?
I am not a reader. 3 paragraphs in, I'm falling asleep. I'm more of a visual learner and hands-on learning. I did not have the privilege of having decent PowerPoints. I'm pretty sure the PowerPoints from my school were developed at least 12 years ago, and were pretty empty. So my school did provide a semester and then the list of concepts, because we were concept-based, and then the list of the exemplars that came under that concept. And so I would take those and find outside resources, whether it's Saunders, NRSNG, there's a bunch of YouTube videos of, nurses teaching the concepts, and then I would make sure I focus on nursing interventions for that, and then have an understanding of what the process is in the body, and so why those are the nursing interventions. And that's pretty much how I made it through nursing school, honestly.
Thank you. Heather?
I'm a very auditory and, kinesthetic when you do it with your hands, learner, and I'm in the car all the time. I went to school 45 minutes away from home. My kids played travel sports. We were always gone, so it seemed to me like I never had time to sit down and read my book. And finding audio versions of your textbooks is almost impossible. So in the beginning, I started, before I found NRNS, whatever, G. You got too many letters in there, and I can't do it. I would read my chapter or a section at a time, and I would record it. Or I would read it to the baby I was babysitting like he could understand it. Or explain it to him, because if I could explain it to somebody, I knew it. He may babble back and pretend he understands it, or my daughter may take my stethoscope to school and go listen to heart rates on the playground. But I was teaching them, right? I hope, maybe. So I had to talk it out, and I had to explain it. And if you don't have another fellow nursing student or anybody in the healthcare field, it doesn't really matter if they're willing to listen to you or not willing, but they don't have a choice. To me, that helped.
Thank you. Any other questions from the audience? Yes.
When I was taking my prereqs, I was able to record my lectures, and I liked listening to those back. But that was in North Carolina. I'm in Texas now. I don't know if I'm going to be able to record my lectures. When I asked about that in my prereqs, they did not like that idea. So I don't know if I'm going to be able to, but was that something you were able to do, and did you do that in some of your lectures again?
In the state of Texas.
Let me just repeat the question so that they can pick it up. So she was wondering, are you able to record lectures, and is that allowed in the state of Texas to record the lectures and then listen to them over again?
In the state of Texas, you do have to have permission from the speaker to record them. So it would just be the first day of class, we'd make a point of asking them if we could record their lectures throughout. I never had an instructor that told us no.
Any other questions? All right, last question is, will I ever make it through? Let's have each of you respond.
Without a doubt. Even if you halfway through you decide nursing is not for you, there's a plethora of jobs in the health field that may be more your liking. RT, radiology, physical therapy. If you have a heart for helping people, nursing may not be your thing, and you may find that out, and that's okay. But own it, and then figure out where your place is in the healthcare industry to help people. There is a place for you. Always have a positive mindset. Never take an excuse. Things are going to come up. It's called the nurse curse. It happens. Whether when you go in for surgery, everything that will happen, can happen, will happen. In your life, it happens too. Suddenly your kids are sick, your parents get divorced, it happens. No excuses. You're going to make it through. And to keep a positive mindset, because it's going to be hard. Nursing school will push your face in the dirt, but you want it to be hard, because when you take your family members to the hospital, you want that nurse that made it through a very hard program. You don't want nurses to be someone that if they showed up, they made it through, and then them taking care of your kids. So keep that in mind, and remember that this is supposed to be hard, because this is a very important career, and you're affecting people's lives.
I'm warning you now, I'm going to cry. Yes, you will make it through, and I want to tell you my story a little bit. When I got back from Iraq in 2008, I suffered from PTSD. I still suffer from PTSD, and that's okay. Mental health is so important. When I first found NRSNG, and nobody's heard this story, I didn't think I was going to make it through. I felt like a failure, not only in nursing school, but in my life. My marriage was trash at the time. I felt like a failure as a parent because I felt like I wasn't present. I had just failed med-surg by 0.2%, and I was ready to kill myself. I was done. And hearing John and Nicole and everybody else say that you can do it, it is going to be okay, and you will make it through, saved my life. So NRSNG saved my life in more ways than one, and I'm here, and I graduated. And you can. You can.
Thank you. Thank you. Jonathan, will they make it through?
I certainly hope so, because I'm still in my 4th semester. But yeah, I mean, take it one step at a time. Once you get your, once you start your program and get an idea of what the expectations are, once you start your semester and get a list of your topics and your assignments and your readings, put them all down, and then just take it one step at a time. Don't try and think about all of it all at once. Get it organized, and then trust your organization system and focus on one thing. What's the next thing I need to do? Because it's a lot, and now that I'm almost done, it feels like it went really quick, but it definitely didn't feel that way the whole way through. So don't stress yourself out too much along the way. That'll happen on its own.
Thank you. Thank you all. Let's give them all a big round of applause. Thank you so much.
So there's a lot of things in OB nursing that can be really confusing. One of those things is fetal heart rate accelerations and decelerations. Luckily, there's a really helpful mnemonic that can help with that. That mnemonic is VEAL-CHOP. We use this mnemonic to help us understand what's actually going on with the fetal heart rate when we see either an acceleration in that heart rate or a deceleration in that heart rate. So once you understand and learn this mnemonic, you're going to be able to answer any question in nursing school or on the NCLEX when it comes to fetal heart rate accelerations and decelerations. Now, if you end up working in OB nursing, it would be important, obviously, for you to dig much deeper into this. So what do these letters stand for? What does the VEAL stand for and what does the CHOP stand for? So when you write this down on your paper, you're going to write VEAL on one side, V-E-A-L, and then you're going to write CHOP on the other side, C-H-O-P. So the V corresponds to the C, the E to the H, the A to the O, and the L to the P. So what do these different letters stand for? Now, if we see variable heart rate, that stands for cord compression. So the V in the VEAL and the C in the CHOP. So variable heart rate stands for cord compression. So if we see that variable heart rate going on, we know that most likely the infant is experiencing cord compression. Now, if we see early, that stands for head compression. Okay, the